ಸ್ಪೇಸ್ ಮಾಡಿದ್ರೆ ನಿಮ್ಮ ಹೆಸರು ಪ್ರಜ್ವಲ್ ಅಲ್ಲ?
Good afternoon, all the delegates. A warm welcome to you all to this afternoon session on 13th of February to the 39th Kscasicon 2021 virtual conference. We are going to start now from 2 to 3, a session of poster presentations. I hope all the presenters are here. And we're just announcing the names of them. Is Monica there?
Yes, ma'am. I'm here.
Yeah, Monica, you will be the first one to present.
Yes, ma'am.
And I'll be inviting the chairpersons now.
Sure.
To this session, we have Dr. Tejasvi Kumar, who's assistant professor at KIMS, Bangalore. Sir, welcome, sir. Dr. Tejasvi Kumar.
Thank you, ma'am. Thank you.
Welcome to the session.
Thank you very much.
I'd like to invite Dr. Amruta Baswa from Dharwad. He's a consultant at Shreya Hospital from Dharwad. Welcome, sir.
Good afternoon, staff.
Good afternoon, sir.
Hello.
Yeah. Sir, Tejasvi Kumar, sir, you are there?
Yes, ma'am.
Thank you, sir. We are going to start the presentations now. It's a poster presentation. The timing is 3 minutes for the presentation, and there is 2 minutes for the questions to be answered. So I hope the presenters will start promptly. We'll screen share the presentation, and you're going to stop by 3 minutes. We're going to tell you if you're going to overshoot that. Okay? I think Monica is ready now. We'll start her presentation. Yeah, Monica, your time starts now.
Yes, ma'am. Good afternoon, everyone. Today I will be presenting about a rare case of post-operative acute adrenal crisis and the importance of this in the perioperative care. Next slide, please. Coming to the introduction, adrenal crisis is a potentially lethal entity that is rarely reported after surgical procedures. And the incidence of adrenal crisis is about 9.0 per crisis per 100 patient years at risk. And the mortality rate is about 0.5 per 100 patients per year. And patients in adrenal crisis present with fever, tachycardia, and hypotension, which are very similar to the post-operative sepsis symptoms. Next. In our case, it is a 65-year-old gentleman who comes with history of swelling of the left foot and leg since 3 days, which was increasing and was associated with pain and blebs over the left leg. And there was history of chronic joint pain for which he was taking tablet methylprednisolone 8 mg for 1 year and has abruptly stopped for last 3 days. And on further evaluation, HbA1c was also high. Next. Initially, dose of 100 mg of injection hydrocortisone was given IV, and the patient was taken up for emergency fasciotomy and debridement in view of compartment syndrome. Immediate postoperative period was uneventful, and patient was discharged home. But 1 week later, patient comes back to the casualty with history of difficulty breathing and reduced responsiveness. On examination, there was tachycardia, hypotension, and respiratory rate was high, and saturation was not maintaining without oxygen. And local examination, wound was healthy with minimal slough, and there was no signs of local signs of sepsis. And on further fluid replacement was given, but hypotension was not subsiding. So on further evaluation, because of methylprednisolone history, cortisol level were checked, and it was found to be 4.4 microgram per deciliter. And endocrinology opinion was sought. Injection hydrocortisone 100 mg IV stat along with 50 mg 6th Harley was given till the vitals stabilized, and then patient was monitored and was discharged with oral steroids. And on further follow-up, it was found that the patient had dry gangrene of the 3rd, 4th, and 5th toe of the left limb. And on Doppler, there was only minimal atheromatous changes without any major vessel block. So 3rd, 4th, and 5th toe disarticulation was done under spinal anesthesia in view of dry gangrene and with the cover of steroids. Next. Regular dressing. This was immediate post-operative picture, which looks the wound looks healthy. Next. Next, please. Dressings were done, and the patient underwent split skin grafting after a while under the cover of steroids. Now the patient has been tapered off the steroids and he is healthy. Coming to the discussion, acute adrenal crisis occurs in patients who are usually already seriously ill as a result of thromboembolic disease, coagulopathy, traumatic shock, or severe burns. Pathophysiology found is if there is a there will be stress-induced increase in ACTH, which increases the adrenal blood flow that exceeds that of the venous discharge drainage. Next.
Time over.
Transient cortisol deficiency is seen in about 5% of patients post-operatively, and the awareness is less. We have to think about this whenever there is hypotension despite of fluid replacement. And the treatment, how we diagnose is by checking serum cortisol, and if at all borderline, then we have to do cosintropin test. The conclusion is basically we have to be aware of something called HPA axis suppression, and we have to know how to manage it. The management is very simple once the diagnosis is made.
Yeah.
That is.
Yeah, the time is over.
Yes, ma'am.
Sir, any questions?
What are the other causes for adrenal crisis?
So basically, this is seen mainly in the severely critically ill patients, sir. Whenever they have sepsis, so they will have relatively cortisol, which will be increased. Whenever there is drug intake, there will be suppression of this axis. So immediate post-op, there might be crisis, and in septic, in patients with sepsis, they will have adrenal crisis. And other things are whenever there is hemorrhage in the adrenal gland, thromboembolic events.
You are ready?
Dr. Monica.
Yes, sir.
Did you mention any antibiotics which was given in your case?
Sir, yes, sir. It was given, sir, post-operatively and pre-operatively. I mean, pre-operative antibiotics was started, and post-operative also it was continued for 5 days, sir.
Okay. What is preferred antibiotic post-operatively?
For this patient?
Yeah, for your patient.
Sir, because the patient was in compartment syndrome, we would like to start on higher antibiotics like Piptas, sir, and also we have to give metrogel also. I mean metronidazole also to cover anaerobic organisms.
Okay, can you tell me what patients are at risk for adrenal crisis? Like any surgery is a stress, is it not?
Yes, sir. Yes, sir.
So can you just tell me what kind of patients you have to be, cautious for? You can expect for post-adrenal crisis? Post-operatively, yeah.
So any major surgeries, sir, who a patient undergoing, if we are giving general anesthesia, they will have relative adrenal gland suppression post-operatively. So mainly in major surgeries where general anesthesia is given, and infection is also there along with that.
Okay.
So.
One last question, Dr. Monica.
Yes, sir. Yes.
Any general anesthetic agent which would lead to adrenal crisis?
Not aware of it, sir. So.
No problem. Thank you.
This has gone back, no?
Yes, ma'am.
Yeah, the time is over now.
Yes, yes, ma'am. Thank you, ma'am.
Thank you.
Thank you, sir. Thank you, sir.
I have to go back. We'll go to the next presenter today of today's presentations. Is Ms. Divya ready?
Yeah.
Divya, are you ready?
Yes.
Yeah, you can start now.
Good afternoon. My name is Dr. Divya from PMC. I'm here to present a poster on adenocarcinoma of the appendix, mimicking acute appendicitis.
Next.
Ask her to tell you. No.
Yeah, Divya.
Introduction. Malignant neoplasms of the appendix are rare entities and account for only 0.4 to 1% of all GI neoplasms. Of these, aspects.
You're not audible.
Of these carcinoids are common. Adenocarcinomas are rare, most commonly occurring in the 6th to 7th decade of life.
We
It's
cannot
like male predominance, and that will make
Problem.
let them.
In this study, we are presenting a case of acute appendicitis in an elderly male with a known history of cholangiocarcinoma, treated with
We cannot offer video. That's what's happening.
Old audio ಚೆನ್ನಾಗಿಲ್ಲ.
Yes, ma'am.
No, it's not our problem. Is it your problem?
Dr. Divya, can you speak up?
Sir, you can hear me?
Yes, sir. Can I go ahead, sir?
Dr. Divya, please switch off your video so that we can
Yeah.
proceed with only audio.
Okay.
You can remove your earphones and try, Dr. Divya. I think that's the problem.
Okay, sir. Is this better,
Yeah,
sir?
this is better. I'll just start.
Yes, ma'am.
Yeah. The
Yeah.
case report.
Yes, ma'am. Yeah, case report. A 69-year-old male presented with complaints of right lower quadrant abdominal pain. Patient was a known case of cholangiocarcinoma and had undergone ERCP and stent placement previously. He had no history of fever, significant weight loss, abdominal mass, altered bowel habits, or nausea, vomiting. On examination, patient was found to have right iliac fossa tenderness, no rebound tenderness noted, and no icterus. Next slide, please. On investigation, patient underwent USG abdomen and pelvis, which showed an inflamed appendix of 6.8 mm caliber with minimal free fluid in the pelvic cavity. On CT abdomen and pelvis, patient had a heterogeneous enhancing lesion in the left lobe of the liver, with moderate IHBRD, likely to be cholangiocarcinoma with a CVD stent in situ, and lesions in the mesentery and the omentum, likely metastatic, minimal ascites. Next slide, please. Coming to the management of this patient, based on the clinical and radiological diagnosis of acute appendicitis, patient had undergone open appendectomy. The specimen was sent for histopathological examination. The perioperative period was uneventful and the patient was discharged in stable condition. Next slide. The specimen on histopathology, the external surface of the appendix was unremarkable. The cut section, however, revealed a 2 × 1 centimeter mass in the tip of the appendix, obstructing the lumen of the appendix. Individual cells were arranged in a glandular pattern with high NC ratio, features consistent with adenocarcinoma of the appendix, metastatic or primary. Next, please. Coming to the discussion, appendicular neoplasms account for 0.4 to 1% of GI neoplasms and are most commonly carcinoids, and the remaining can be mucinous cystadenomas or adenocarcinomas. Primary or metastatic adenocarcinomas are rare, and the incidence is about 0.1% of all appendectomies. Preoperative diagnosis is difficult as it mimics acute appendicitis, and diagnosis is usually in the post-operative period on histopathological examination. Minimal treatment for adenocarcinoma is a right hemicolectomy, even if it's a secondary surgical procedure after the histopathological report. To conclude, adenocarcinoma should be kept as one of the differential diagnoses in a case of appendicitis in an elderly male, and the specimen has to be sent for HPE. Thank you.
Yeah, open for discussion, sir.
Yes, sir.
So, Dr. Divya, you said cholangiocarcinoma.
Yes,
what was done for cholangiocarcinoma in the case?
So, patient was diagnosed with hello.
Yeah, tell me.
Yes, a patient was diagnosed with cholangiocarcinoma outside syndrome, and he had undergone ERCP and stent placement to relieve the obstruction.
No, it's ready.
But your CT showed growth in the right lobe of the liver, not in the CBD. There was no comment on the CBD. So how did you tell it's a cholangiocarcinoma?
No, sir. When the patient presented to us, he had already been diagnosed with cholangiocarcinoma with a stent in the CBD, sir.
Okay,
He's sharing.
so it's
Yes.
inoperable.
On ERCP, he was diagnosed on ERCP, sir.
Okay, so it's an inoperable case of cholangiocarcinoma. That's why you went
Yes, sir,
with
it was
appendectomy?
inoperable, and also because of the patient's age, he underwent stenting instead of surgery, sir.
Okay.
Yes, sir.
Dr. Divya,
Yes, sir.
can you repeat what is the percentage of acute appendicitis which turns out to be adenocarcinoma at a gross, at an average? I think it's 0.1% you mentioned, is it not?
Yes, sir. 0.4 to 0.1%.
Okay.
But
Can you?
after on HP, 0.08 to 0.1% is because of adenocarcinomas.
I get it. So can you suggest any tumor markers which could be helpful?
Yes, sir. CEA, that is the carcinoembryonic antigen, is one of the tumor markers which is elevated in GI malignancies.
Sir,
Okay.
yeah,
Yes, sir.
I think we can stop. Time over.
Okay. Good.
Yeah, Dr. Suhas, are you ready?
Thank you, ma'am.
Yes, ma'am. I'm ready.
Yeah, you start your presentation.
You'll do next.
Yeah. My case report is on May-Turner syndrome. Introduction: this deep vein thrombosis is a common entity encountered in the medical fraternity and most common cause of pathophysiology. So overall, the treatment consists of prevention of risk factors and the treatment of the thrombogenic phenomena. However, there can be certain situations where normal anatomical aberrations in the absence of risk factors can cause DVT. In such cases, the anatomical aspects needs to be tackled apart from the treatment of thrombosis. We hereby present a case of normal aberration in the blood vessel causing deep vein thrombosis known as May-Turner syndrome. Next. So this is a 37-year-old gentleman who presented with pain in the entire left lower limb from left hip to foot since 2 months, more so in the thigh, aggravated since 2 days, and associated with swelling in the calf. There was no prior history of trauma, immobilization, or major surgery. No associated history suggestive of arterial disease or soft tissue infection. There was no other comorbidities. Next. On examination, there was swelling over the left calf with tenderness. There was no localized temperature, skin changes, or erythema. Peripheral pulsations were well felt. No other abnormalities on the examination. So, with the provisional diagnosis of deep vein thrombosis of the left lower limb, next, we went ahead with the venous duplex scan, which showed compression of the left common iliac vein with pre-stenotic dilatation, indicating external compression, most likely due to the right common iliac artery, suggestive of May-Turner's. So it was further confirmed by CT abdominal iotogram. In this picture, we can see the right common iliac artery with the contrast in it, compressing the left common iliac vein against the L4 vertebra, lumbar fourth vertebra. Next. The same picture in the axial view, we can see the right common iliac vein is visible well, whereas the left common iliac vein is compressed by the right common iliac artery. Next. So with this diagnosis, he was managed conservatively with anticoagulants during the acute episode, with follow-up and a plan for left common iliac vein stenting and inferior vena cava filter later. So the discussion, it was first described in 1957. It is a normal anatomical aberration. So Augustus et al. Hypothesized that almost 70% compression of left common iliac vein is needed to produce DVT. Compression of the LCIV in MTS alone does not cause DVT until there is chronic intimal hyperplasia resulting in venous stasis and thrombosis of spur. Next. So it is most common in female due to the wider pelvis and because it pushes the lower lumbar vertebra against the vein. And investigations, it is not easily picked by ultrasound. The best modalities are contrast venography, MR venography, or intravenous ultrasound. CT arteriogram can help in further substantiating the diagnosis. Next. Treatment is a stepwise approach with initial anticoagulation followed by LCIV stenting and a concomitant IVC filter. Our case posed a challenge to us as there was difficulty in passage of the stent due to thick intimal spur. Next. Concluding, we have brought up this rare cause of common disease in the form of May-Turner syndrome, which can cause unprovoked deep vein thrombosis. Hence, it is of paramount importance that such anatomical variants must also be kept in mind while treating the condition of deep vein thrombosis of unprovocable causes. Thank you.
Sir, open for discussion.
Dr. Suhas?
Yes, sir.
So May-Turner syndrome is a rare condition, is it not?
Yes.
Can you tell me the incidence?
It is less than 0.4 to 1%, sir, the incidence.
0.4 to 1%. Okay.
So, some of the literature says 0.4 to 1 and some is less than around 0.4%.
Okay. What is, how did you manage this case? Can you repeat? Like, is it surgical?
No, actually, it is stenting is required for the left common iliac vein and IVC filter is the main treatment of choice. But in our case, there was intimal spur was there with cardiologist opinion. They said due to that spur, he can't be stented as of now. So we treated with anticoagulants to thrombolize the clot and later plan of left common iliac vein stenting.
Any surgical option you would think of?
The best treatment as of now is left common iliac vein stenting and IVC filters. So that is the thing.
Okay, is there something in some role in thrombectomy?
Thrombectomy.
Like surgical
yes,
thrombectomy
do have a role, but the first is this stenting. If it is not
stenting.
working, then the thrombectomy is
okay.
correct.
Good.
Thank you.
Go ahead, madam.
Yeah. Am I audible now? Yeah, the next presenter is Dr. Mallela Lakshmi Sri Durga.
Yes, ma'am.
Yeah, you can start.
Yeah, good afternoon, everybody. I'm presenting a rare presentation of Lemierre's syndrome as submandibular abscess. Next slide, please. Next slide, please.
Yeah, 1 minute. Yeah.
Yeah, Lemierre's syndrome is a condition characterized by thrombophlebitis of internal jugular vein and bacteremia caused by primarily anaerobic organisms following a recent oropharyngeal infection. This syndrome has become uncommon in the antibiotic era. This disease should be suspected in healthy individuals with prolonged pharyngitis following a respiratory tract infection or atypical neck pain or swelling. Diagnosis often confirmed by identification of thrombophlebitis of internal jugular vein and growth of anaerobic bacteria on blood culture. There is no case report of IJV thrombus with neck abscess surrounding it in a patient suspected to have Lemierre's syndrome in reputed medical literature. Hereby, we present a case of Lemierre's syndrome with rare presentation. Next slide, please. Next slide, please. Yeah, this is the presentation of the patient with right-sided neck swelling. Next slide, please. Yeah. A 39-year-old male patient presented as a surgical OPD with a swelling in the right side of the neck since 1 week and neck stiffness since 3 days, associated with difficulty in swallowing. The patient reported 1 episode of sore throat 10 days back, but no history of fever, chills, cough, chest pain, shortness of breath. On physical examination, the patient was febrile and restricted mouth opening was present. Tongue tonsils are normal and no caries tooth. Swelling of 8-6 cm present in the right side of the neck near the jugular digastric region. Swelling is tender, soft, cystic in nature. Blood investigations reveal leukocytosis. Serology is negative, TrueNat is negative. Next slide, please. Ultrasound showed right IJV thrombus with decrease in the color flow proximal to the thrombus and hypoechoic lesion measuring 8.7 into 7.9 centimeter noted in the deep subcutaneous plane on the right side of the neck in the level 2 and 3. NCCT showed large necrotic nodal mass in the jugular digastric and mid-jugular regions on the right side of the neck with right IJV thrombus. CT suggested CB-NAT to rule out tubercular etiology, which was reported as negative. CT chest showed no abnormal deposits and patient was then operated on general anesthesia for abscess drainage. Pus for culture sensitivity showed Klebsiella on blood cultures. Postoperatively, patient was started on empirical antibiotic combination of amikacin, metronidazole and Clexane 0.6 mg IV for thrombolysis. On follow-up, serial ultrasound imaging showed decreasing IJV thrombus. Patient was then prescribed oral anticoagulants for 1 week. On discharge, the patient was advised interval tonsillectomy after 6 weeks. Neck swelling with IJV thrombus can be due to a number of causes such as malignancies, IV drug abuse, estrogen treatments, hypercoagulable states, Lemierre's syndrome, etc. Lemierre's syndrome usually presents with signs of raised intracranial pressure, neck swelling, atypical neck pain with septicemia. Thrombus and IJV embolizes mostly to the lungs and the eyes, may cause pulmonary embolism, papilledema, respectively. Aggressive treatment advised with IV antibiotics, anticoagulants, early surgical intervention as needed. Abscess formation is rare, but if present, should be drained immediately after ruling out tuberculosis. The rarity of the discharge disease and the subtle presentation makes the diagnosis difficult. High degree of suspicion and investigations like CT scan, which is the gold standard, and color Doppler for follow-up with blood culture is necessary. CT showing right edge.
Time is over. Just conclude.
Okay. Yeah. A high degree of suspicion is necessary in case with neck swelling with toxic signs to consider Lemierre's syndrome, though it is rare as it can be fatal if the diagnosis is delayed.
Yeah, open for discussion.
Define Lemierre syndrome. How do you define Lemierre syndrome?
So Lemierre syndrome is it occurs usually after a oropharyngeal infection, usually in 16 to 25 years age group people, and they usually present with either they're present with neck swelling, or they may be presenting with difficulty in respiration or signs of raised intracranial pressure due to IJV thrombus, sir, because of the embolization of the IJV thrombus.
The most common bacteria in Lemierre syndrome?
Sir, most common bacteria is I don't remember.
Dr. Lakshmi,
sir,
can you tell me the incidence? You said it's a rare case, so can you tell me the incidence of this?
Sir, Fusobacterium necrophorum is the most common cause, sir.
Okay.
Sir, sir, your question, sir, I forgot.
Okay. Can you tell me how rare is this Lemierre syndrome? What is the incidence?
Sir, 0.6 to 2.5% in like 10,000 people, sir. Presentation.
Okay, and how many people with sore throat can you expect this, like out of 100 or in percentage? With sore throat, this follows after a sore throat, is it not?
Yeah, yes, sir.
So, how many percent after sore throat can you expect this Lemierre syndrome?
Sir, sore throat with other, if any associated like embolic features, very rarely we can expect this presentation, sir.
Okay.
So can we go to the next presenter? I think the time is over, sir. Can we go to the next presenter?
Yes, please.
Yeah. I'll be inviting Dr. Suhas now for the next presentation. Are you ready, sir?
Yes.
Dr. Suhas?
Yeah, hello.
Yeah. Dr. Suhas?
Coming to the next poster.
Yeah.
This is a case of concomitant malignancy in the neck, follicular dendritic cell sarcoma, and papillary carcinoma thyroid.
Okay.
So this is, coming to the follicular dendritic cell sarcoma, this is a low-grade sarcoma of a mesenchymal dendritic cell organ, with the fifth decade being the most common and equal gender predisposition. So it is the most common type of dendritic cell neoplasm. It is associated with paraneoplastic syndromes like Castleman, myasthenia, and pemphigus vulgaris. Here we report a case of FTCS of the right cervical node with papillary carcinoma thyroid in a 43-year-old lady. Next, this lady present with painless swelling in the right side of the neck 1 year, 2 months. Insidious onset gradually progressive with sudden increase in size in 2 months. No other symptoms with respect to the swelling or any drainage areas of the swelling. Next, so on examination, it was a 10 to 12 centimeter size firm swelling extending from the midline towards posterior sternal cleidomastoid from the angle of the mandible towards the lower part of the cricoid cartilage. Firm, and it was the mobility was restricted. Next. So with the diagnosis of lymph nodal mass, we evaluated with the ultrasound scan, which showed a small nodule in the right lobe of the thyroid with query papillary transformation and bilateral cervical lymphadenopathy, largest in the right submandibular with 4 to 2 centimeters. So the FNH of the both was done, which showed poorly detected carcinoma. So to look for the primary sites, we went ahead with the upper GI endoscopy, CT abdomen, neck and thorax, and video laryngoscopy, which there was no other primary was found except other than the enhancing lesion in the upper quadrant of the right breast. So otherwise, all other features are normal. So next, we went ahead with Q-cut biopsy with IHC, which showed CKA1 and AHC positive, patchy synaptophysin positive. Next, and so with this, the differential and undifferentiated carcinoma, neuroendocrine tumor was done. So if that breast lesion was under biopsy using the ultrasound scan, but it came as negative. Next, so after this undoubtful diagnosis, we went ahead with an incisional biopsy. Which next. Next slide, please. We went ahead with the incision as a biopsy of the right cervical lymph node, which showed CD21, 35, CD20. So the final impression was follicular dendritic sarcoma, and it showed FDG evidence the right cervical node, right lobe of thyroid. Next, so with lymph node with thyroid as an extranodal lesion, we discussed with the tumor board and went ahead with the surgery. It was total thyroidectomy, ipsilateral MRI, modified radical necessity, and removal of the level 6 nodes. Next, so this picture shows, the first picture shows the intraoperative finding, where the 1 depicts the level 1C node, 2 is the level 2 and 3 lymph nodal mass, whereas the 3 is the right lobe of thyroid nodule. The second picture is the post lymph node dissection. That is, the 4 is the angle of the mandible, 5 is spinal axis now. Next picture. So in this picture, we can see the big nodal mass. Next, the 1 is the level 2 and 3 lymph node, and whereas the smaller 5 is the so 2 is the level 5 nodes. Next, so the histology. Next, histology slide showed rolling of cells into with oval round oval nuclei with indistinct nucleoli. Next, the immunohistochemistry, which showed CD21 and 23 positive. So with the diagnosis of follicular endothelial sarcoma of the thyroid and papillary carcinoma of the right lobe of thyroid, we went ahead with further corrections. Post-op period was uneventful. Radioiodine scan after 6 weeks showed thyroid tissue. So radioiodine therapy was given. So radiotherapy for the FTCS has been continued. So coming to the discussion, is slow-growing painless mass, most commonly are at the nodal sites, and extranodal FTCS has also been reported. Most cases present localized disease. Systemic symptoms are uncommon. Next. So the histological features are spindle-shaped cells with oral bundles with fasciculus tubercular diffuse sheets. IHC shows CD21, 23, and 33 positive. Next. So diagnosis. Next is often misdiagnosed. Pathology, IHC, PET CT can help in arriving at the diagnosis. The treatment surgery is the best treatment. The recurrence rate of 50%. Adjuvant therapy is indicated for if the localized disease, radiotherapy, and systemic disease, chemotherapy with no proven trials. So concluding, this is a rare disease involving the cervical nodes and associated paraneoplastic condition. Our case with association with papillary carcinoma thyroid expands the spectrum of diseases and associated conditions. However, a rare entity, better understanding of the condition and its features will help in diagnosing this condition. Thank you. Next.
Yeah. Open for discussion. And is Dr. Ashwini there? The next speaker is Dr. Ashwini. Is he there?
Not there.
You put this.
Any other differences you wanted to take? Yes, Dr. Suhas.
Take up Jayashree.
Yes.
Dr. Suhas.
Is there with you?
Yeah.
Madam, I think we missed the question for the previous candidate.
Dr. Suhas?
Hello.
Yeah,
Dr.
he's there.
Suhas.
Yeah, unmute yourself. Yeah.
Yeah. Any other differentials you wanted to give for this case? Any other differences you get confused with?
The first diagnosis was carcinoma only. So with FTCS was a rare diagnosis. We come with the first diagnosis. We looked for the primary in the oral cavity, oropharynx, the larynx, everything was ruled out. So then we sent it for biopsy, the two-cut biopsy with immunohistochemistry that also came as a doubtful diagnosis. So next was the incisional biopsy with the diagnosis came as FTCS.
Dr. Suhas?
Yes, sir.
Can you tell me what is lateral aberrant thyroid and how can you correlate your case with this?
Yes, sir. Lateral aberrant thyroid is the only lymph node where the papillary carcinoma thyroid can occur, with the thyroid being not palpable and no nodule is felt. So, but the diagnosis will definitely show features of papillary carcinoma thyroid. But in our case, it was two differential diagnoses.
Good.
So that was it. Until the post-operative biopsy report, we couldn't diagnose it as papillary carcinoma.
Okay, good presentation. Next.
Thank you. Thank you.
Oh, sorry. Is there Dr. Ashwini there? Dr. Ashwini, no. Okay, the next presenter. Can somebody unmute the... I think Dr. Suhas, you need to unmute. Yeah. Dr. Jayashree, are you ready?
Yes, ma'am. I'm ready, ma'am.
Yeah. It'll be your presentation next. Okay.
All right, ma'am. Good afternoon, everybody. Ma'am, can I start?
Yeah, you can start.
Okay. Good afternoon, everybody. I'm going to present a report on a rare site of presentation of the B-cell lymphoblastic lymphoma, which is an extranodal presentation. Next slide, please, sir. Lymphoblastic lymphoma is a neoplasm of the immature B cells that account for approximately 2% of all the lymphomas. Lymphoblastic lymphoma is highly aggressive but frequently curable with the current therapy. The prognosis in all age groups has dramatically improved with the use of intensive acute lymphoblastic lymphoma type chemotherapy regimens with a disease-free survival of 73% to 90% in children and 45 to 72% in adults. Next slide, please, sir. Next slide, yeah. We had a 5-year-old child who presented to us with complaints of swelling in the left temporal region for 2 months duration, and the swelling in the left side of the neck for 2 weeks duration. The swelling was progressively increasing in size and was found to have and was not associated with discharge or any skin changes over the swelling. The child also had complaints of high-grade continuous fever for 4 days. No known comorbids. There was normal birth and developmental history. On examination, the child was moderately built and nourished. Vitals of the child were stable. Local examination showed 4x3 centimeters, non-tender, firm, hyperpigmented mobile swelling in the left temporal region, which was non-pulsatile, and a 5x5 centimeters firm swelling in the left cervical region. No discharge seen, non-pulsatile, and no other nodes were palpable in the neck. Next slide, please. This is how the child presented to us in the OPD. Next slide, please. Child was evaluated and FNAC of the left temporal swelling was done, which showed smear with lymphocytes and smudge cells on a background showing blood. No keratin seen. Child was then planned for left temporal swelling, excision and biopsy with split skin grafting and excision of the left cervical region swelling. Lesion of the left temporal region was seen well above the pericranium and was adherent to the skin and the subcutaneous tissue. Cross section of the specimen appeared like fish flesh. Split skin grafting was done for the raw area. Specimen was further sent for HP and immunohistochemistry. Biopsy report concluded to be B-cell lymphoblastic lymphoma, positive for markers like TDT, CD79A, CD45, CD43, and negative for CD3 and CD20. Child was then started on tablet prednisolone 60 mg OD dose with injection vincristine, injection daunorubicin, injection levoasparaginase, and injection cytarabine. Treatment was taken for 6 months, and then a PET scan was repeated, which showed complete metabolic response to the therapy. This shows the PET scan picture. Next image shows the PET scan image of the cervical lymph nodes, which was taken after 6 months, which has shown remission of the disease. Next slide. Next is the microscopic image showing fish flesh appearance and lymphocytes. Discussion. B-cell lymphoblastic lymphoma is a rare type of fast-growing non-Hodgkin's lymphoma. It is commonly extranodal, with skin being the most commonly involved, followed by lymph nodes, which show 22% involvement, followed by bone and mediastinum. Lymphoblastic lymphoma has a preference for the bone marrow, with a reported frequency at diagnosis of 21%, as well as a reported frequency of 5 to 10% for the central nervous system. CNS involvement is more commonly...
You can conclude now. You can conclude now.
Okay, ma'am.
Your time is getting over.
Yes, ma'am.
Not over.
Child underwent chemotherapy for about 6 months and is in a phase of remission now. So now I'd like to conclude by saying that 90% of the B-cell lymphoblastic lymphomas are curable with regular treatment and close follow-up.
Yeah. So open for discussion.
Dr. Jayashree.
So yes, sir.
Can you tell me common sites for T cell and B cell? How can you compare? Is there any affinity for T cell and B cell? Any difference in affinity for sites?
So usually lymph nodes.
So T cell, you say it's lymph nodes, and B cell extranodal, is it?
So there's increased propensity to affect the extranodal sites. There's more affinity in case of B cell to affect the extranodal sites. So.
Okay, good.
Dr. Vinod is not there. Dr. Vinod? No. Even Dr. Ashwin is not there, not logged in. Okay, we'll move on to the last presenter, Dr. Muthu Vignesh. Are you ready, sir? Vignesh?
Hi.
Yeah.
Yes, ma'am.
Your time starts now.
Yes, ma'am. I'm going to present a rare case now, post-cystectomy adenovenous fistula. Next slide, please. AV fistula is defined as an abnormal connection between the artery and the vein. We have to see the material in my study. A 45-year-old post-cystectomy female came with complaints of swelling over the left lower limb, which was gradually enhanced and progressive from foot to thigh. And there is no aggravating or relieving factor. And associated with pain, over the left limb, which was the past 1 year, which is a pricking type of pain. There is no aggravating living factors and non-healing ulcer over the left limb for the past 10 days. There is no other complaints. He had no other comorbidities. Previously, he had a history of lower limb DVT, that is 1 year back, developed on the post-operative day 11 on the hysterectomy and treated with IV anticoagulants, followed by the oral anticoagulants. And she had a persistent left lower limb swelling for which CT angiogram was done, taken at the time of surgery. On examination, it shows hyperpigmentation of the left lower limb and ulcer of size 4x3 cm with the edema from the ankle to the below knee. And actually, the serious discharge was there. And a few more superficial varicosities over the left inguinal region. All peripheral pulses are felt. USG venous Doppler shows no signs of DVT, but a few dilated superficial varicosities in the left inguinal region. Then we move on, proceeded to the CT angiogram was done that shows a fistula between the left internal iliac artery to the left external iliac vein with multiple tributaries and collaterals and associated with the partial thrombosis of the left common iliac vein. These are the pictures. It shows the patient had a multiple collaterals over the suprapubic region and discoloration of the lower limb and along with the ulcer. And these are CT images shows multiple collaterals over the left lower limb. In discussion, we have to see the arteriovenous fistulas are characterized by the abnormal communication between the artery and vein. That is, an acute iliac fistulas can be result from any lumbar disc surgeries, pelvic surgeries, or penetrating trauma or iotoiliac aneurysm can cause. AV fistula can also occur due to secondary connective disorders such as Marfan syndrome, Ehlers-Danlos syndrome, neoplastic invasion of the vascular structures, and mycotic or syphilitic aneurysms. And results, in conclusion, iliac AV fistula results from the hysterectomy surgery may manifest a multiple vessel involvement. Diagnosis of AV fistulas may be difficult if it is not suspected due to non-specific presenting symptoms. History of lumbar surgery or pelvic surgery or inguinal surgery and presence of murmur in the groin vessel should raise suspicion of arteriovenous fistulas. And color flow Doppler, ultrasonography, CT and MRI can be helpful in the diagnosis and mapping of the arteriovenous fistula. Endovascular treatment is the safe and appropriate method for the treatment of iliac AV fistulas. This case happened to be a rare case presentation, considering that the arteriovenous fistula following the post-hysterectomy is rare.
Over. That's over?
Yes.
So open for discussion, sir.
Dr. Muthu?
Yes, sir.
Can you tell me some precautions which you need to take to prevent AV fistula in general in any surgery?
So we have to, the patient complains the swelling of lower limb, in discoloration. It means we have to proceed for the ultrasound Doppler. Sir. We have to check any thrombus was there or any malformation was there. We have to see. Then, if in case of if any thrombus was there, then we have to proceed to the CT angiogram. By that, we will see any fistulas was there.
Dr. Muthu, since it's a post-hysterectomy fistula, what do you think is the best treatment for this case?
Hello, sir.
So repeat the question.
Dr. Muthu, can you hear me?
Yes, sir.
Since it's a post-hysterectomy fistula, what is the best treatment for this case?
So it's not audible, sir.
Best treatment for your case?
It's a treatment. It's a treatment should be endovascular treatment, sir. There's a stenting between the iliac artery and the fistula, sir.
Endovascular, good.
Thank you.
Yeah.
Thank you, sir.
I think we come to the end of the session, sir, because two of the participants have not come. That is Dr. Vinod Ingale and Dr. Ashwini have not come. We'll be closing this session. I'd like to take this opportunity to thank Dr. Tejasvi Kumar sir and Dr. Amrit Baswa for having come here and be the chairperson for this session. It was a wonderful session, sir. Thank you so much. We'll be shifting to screen 1 now. From 3 to 5, we have orations there from 3 to 5. So we'll be shifting to screen 1 and the screen will be closed until 5 o'clock. Thank you so much, sir. Thank you. Thank you.
Second one start madam. Vivek is there.
Just ask. Good evening. Good evening, all. Yeah. I think Dr. Suresh Badiga sir and Dr. Bharat sir are logged in.
Yes, ma'am. Yes, ma'am.
Welcome all. Yeah, ma'am. Sir, welcome, sir.
Thank you, ma'am. Thank you, ma'am.
Welcome all to this 39th KCSI virtual conference and screen 3. Here we are having some free paper presentations today from 5 to 6. I'm Dr. Aruna Kamiredi, your host, and co-host is Dr. Prajwal. We'll be managing your screens today. I'd like to welcome Dr. Suresh Badiga, sir. He is Professor SGM Dharwad, and Dr. Bharat, Associate Professor, Rajarajeshwari Medical College. Welcome to this session, sir.
Thank you very much.
I think, yes, I think the first presenter is actually Rahul Rai, and he has not logged in.
Yes, ma'am. We'll wait for him, ma'am.
Yes, because we're going to start in another 2 minutes. We'll just wait for him.
Yeah, ma'am. We'll wait.
Otherwise, I think the second presenter has to be ready here. Vivek, are you ready?
Yes, ma'am.
Are you ready?
Yes, ma'am.
Because the first presenter is Rahul. He is not yet logged in. We'll wait for another 1 or 2 minutes. If it doesn't come, I think by 5 we are going to start with your presentation, right?
Okay, ma'am.
And you all know it's a 8 minutes presentation and 2 minutes for the chairpersons to discuss the case and ask some questions. And we are strict with the timings. Not come, right? Rahul has not come. Screen is screen reader. Yeah. Dr. Vivek, are you ready?
Yes, ma'am.
Yeah, you can start your presentation now.
Good evening, respected faculties. I am Dr. Vivek. Today I am going to present free paper to estimate the role of neutrophil to lymphocyte ratio in predicting gangrenous perforated appendicitis in emergencies and its comparison with hyperbilirubinemia. My guide is Professor Dr. K. Vivekananda, sir. My co-guide is Dr. Bhuvneshwari. I'm from Chetnada Hospital Research Institute. Introduction. Acute appendicitis is one of the most common causes of acute abdomen. The lifetime occurrence of this disease is approximately 7% and with perforation rate of up to 20%. In spite of well-known classical symptoms and clinical findings of acute appendicitis, early diagnosis can be sometimes challenging. Failure to diagnose acute appendicitis at an early stage may result in adverse outcomes, including perforation, which can be associated with significant morbidity and even mortality. In addition to this, several blood tests are being used to predict appendicitis and its severity. White blood cells counts are mostly elevated in patients with appendicitis. However, an elevated WBC count has no predictive value in differentiating simple and complicated appendicitis. Neutrophil to lymphocyte ratio is a simple, inexpensive marker of subclinical inflammation, which is easily calculated from differential WBC counts. Neutrophil lymphocyte ratio provides information regarding two different immune and inflammatory pathways, which may make it potential marker to predict appendicitis and its severity. The neutrophil counts highlights active and continuing inflammation, whereas the lymphocyte count highlights the regulatory pathway. Neutrophil lymphocyte ratio was calculated as ratio of neutrophils to lymphocyte using the differential WBC count on the day of admission. NLR as an accurate marker has a great potential to facilitate decision making in selected populations. Neutrophil lymphocyte ratio, in addition to predicting appendicitis, can distinguish between complicated and uncomplicated appendicitis. NLR may also have implications for patients who do not routinely undergo CT scan, like pregnant and pediatric patients, and in places or settings where 24/7 access to immediate CT is limited. And if NLR is greater than 4.7, was an independent predictor of appendicitis, and if NLR is greater than 8, was the independent predictor of complicated appendicitis. Hyperbilirubinemia is a result of imbalance between production and excretion of bilirubin by the liver. It may be because of hepatocellular, cholestatic, or hemolytic diseases. Liver receives blood mainly through the portal venous system, which receives blood from abdominal organs. Portal blood carries nutrients and other substances absorbed from gut, including bacteria and its products like toxins. But when bacterial load overwhelms the Kupffer cell function, it may cause dysfunction or damage to hepatocytes. It reflects in a rise in serum bilirubin alone or in combination with liver enzymes, depending upon the type, severity, and site of the lesion. Justification of the study. We can predict and proceed for emergency laparotomy in case of gangrenous or perforated appendicitis when the radiological imaging is not clear and can reduce the chances of appendicular perforation and peritonitis. Aim and objectives. Comparison of the role of hyperbilirubinemia versus the role of neutrophil to lymphocyte ratio in predicting gangrenous perforated appendicitis in emergencies in tertiary care center. To check the role of hyperbilirubinemia in predicting gangrenous perforated appendicitis, and to check the role of neutrophil to lymphocyte ratio in predicting gangrenous of perforated appendicitis. Method. Study area, Chettinad Hospital and Research Institute, Kelambakam, Chennai. Study population, patients with symptoms suggestive of acute appendicitis and taken up for appendicectomy. Sample size is 20 patients and study duration 6 months from July 2020 to December 2020. Type of study is prospective study. Method. Study tools are LFT, neutrophil and lymphocyte counts, ultrasound abdomen, intraoperative findings, and histopathological findings. Method. Inclusive criteria. Patients who diagnosed of having acute appendicitis. And exclusion criteria. Appendicular mass or appendicular lump, history of alcoholic liver disease, hemolytic or liver diseases associated with hyperbilirubinemia, and history of gastrointestinal or hepatopancreatobiliary malignancy. Methodology. Patients admitted in Chettinad Hospital with clinical examination suggestive of acute appendicitis were enrolled for this study. All the routine investigations along with LFT and neutrophil and lymphocyte counts were done. Final confirmation of diagnosis is by histopathological examination of the post-hoc specimen. Correlation is made between laboratory investigations, ultrasound, and clinical diagnosis depending upon intraoperative and histopathological diagnosis. The value of neutrophil and lymphocyte counts and LFT is very helpful in management of perforated or gangrenous appendicitis. Results. If serum bilirubin is more than 3.6 milligrams per dl, which is sensitive for complicated appendicitis, is noted, and neutrophil lymphocyte ratio is noted if more than 8, we can predict and proceed for emergency laparotomy in case of gangrenous or perforated appendicitis when the radiological imaging is not clear. And neutrophil lymphocyte ratio, if it is more than 4.7, it is a predictor of appendicitis. These are the results during my observation. Discussion. Neutrophil to lymphocyte ratio is a promising marker that can predict both diagnosis and severity of appendicitis with acceptable sensitivity and specificity. Neutrophil and lymphocyte ratio may play an important role in diagnosing appendicitis in pregnant patients. Neutrophil lymphocyte ratio predicts both diagnosis and severity of appendicitis. This may have implications for prioritizing cases for surgery, for monitoring conservatively treated patients, and for patients who do not routinely undergo CT scan. In conclusion, according to the results, neutrophil lymphocyte ratio is more than 8 seems to be a reliable marker to obtain a more accurate diagnosis of gangrenous and perforated appendicitis. Serum bilirubin is more than 3.6 mg per dl, which is sensitive for complicated appendicitis. In my study, neutrophil lymphocyte ratio is better predictor than serum bilirubin as it is more sensitive and specific. And references.
A good presentation, Vivek. I just want to ask you a few questions actually. Do you know what is the incidence of portal pyemia here?
Sir?
Portal pyemia.
Sir.
Can you hear?
Sir, yes, sir.
Can you hear me?
Sir, yes, sir.
Yeah.
Now audible, sir.
Yeah. Portal pyemia. Because in 20 patients, I saw a lot of patients had raised bilirubin.
Yes, sir.
So that's why I'm asking you, what antibiotics were used?
Sir, we'll use Folbact, sir, ceftazidime and sulbactam, and ciprofloxacin, sir.
How did you decide about the sample size?
Sir?
Sample size.
Sample size?
How did you decide the sample size?
Your sample size, sir, means. How did you decide on that?
Sir, after our IHEC, we decided I submitted in my college, sir. After getting from PSM, I decided my sample size at 20.
Sir is asking, what is the minimum size, the minimum number, sample numbers for any study? Any
Minimum
idea?
10 minimum.
Okay, thank you, Vivek.
Hello.
That's right, sir.
How many appendicitis were turned out to be a normal in your cases? Like you have decided only 20, at least you need to have 30 cases, okay? And it's very small size, you can't come to some conclusion, okay? Sample size is very small. Okay, how much has turned out to be a normal appendicitis in your study?
3 to 4, sir.
No, exactly you tell, no, hardly you have 20 cases.
Yes, sir. Yes, sir. Normal appendicitis 3, sir, mostly.
So histopathologically, there are no evidence of appendicitis in those 3 cases.
It's inflamed, sir. Mild inflamed appendicitis like that. Cancer, grossly normal like that, sir.
So grossly it was normal, but on histopathology you had inflammation.
Yes, sir.
Okay, fine. Okay, thank you.
Thank you, sir.
Thank you. The time is over.
Thank you.
We'll move on to the next presenter. That is Dr. Rahul Rai. Are you in?
Yes, ma'am.
Yeah, you were late for the first session. I think
Yes,
now
ma'am.
you can
That's
carry.
glitch with my
Yeah.
internet connection. Yes, ma'am.
Okay,
Sorry,
no
ma'am.
problem. You can just carry on now. Your
Yes, ma'am.
time starts now.
My paper for today is repair of inguinal hernia under spinal versus local anesthesia, a comparison. Next slide. Introduction. Lichtenstein mesh technique is the most widely used method for inguinal hernia repair, and traditionally, hernia repair surgery was performed mostly under the spinal anesthesia or general anesthesia. Now, the use of local infiltrative anesthesia has also proven as an effective alternative for this. The choice of inguinal hernia repair remains arbitrary, without any current consensus about the choice of anesthesia. Numerous studies have been done with reported advantages of the use of local anesthesia for inguinal hernia repair. Still, it is continued to be used. Spinal anesthesia is used as a method of anesthesia. The aim of the study is to compare hernioplasty done under spinal anesthesia and local anesthesia, and to find out better anesthesia choice for the procedure based on post-operative pain, the length of hospital stay, and complications. Next slide. Materials and method. The study design was a non-blinded randomized controlled trial for a duration of 1 year from January 2019 to January 2020. The inclusion criteria were patients who were more than 18 years of age admitted for the management of primary unilateral inguinal hernia. The exclusion criteria were bilateral inguinal hernia repairs, recurrent inguinal hernia patients, and those with history of hypersensitivity to anesthetic agents, and those who had uh, who had those who had presenting with emergency inguinal hernia. My study comprised of 60 cases of inguinal hernia, which were randomly divided into two groups of 30 each, named Group A and Group B. Lichtenstein mesh hernia repair was done under local anesthesia in Group A and under spinal anesthesia in Group B. All patients were tested for hypersensitivity to lignocaine and bupivacaine by an intradermal skin test. The method of local anesthesia infiltration was that a 40 ml solution was made comprising of 20 ml of 2% lignocaine with adrenaline in the ratio 1:2 lakh and added to 20 ml of sterile water. We identified the anterior superior iliac spine and the pubic tubercle. Now, a 10 ml of this solution was injected at a point 2 centimeters above and medial to anterior superior iliac spine under the external oblique aponeurosis in a fan-wise manner. Then a click was felt as the needle pierces the aponeurosis, and another 10 ml was injected under the aponeurosis from just lateral to the pubic tubercle towards the umbilicus and then laterally. After waiting for a short while, another 10 ml was infiltrated subcutaneously into the line of incision. Another 5 ml of the injected solution that was kept was injected when there was exposure of the sac, hernia sac, and the remaining solution was used to supplement any part that was not adequately anesthetized. After surgery, the patients were assessed for complaints during the surgery, post-operative incision site pain using visual analog scale, pain scoring system, urinary retention, postural hypotension, and other complications. The Wong-Baker Faces Pain Rating Scale was used to measure the severity of perceived pain along a scale from 0 to 10. For this study, 0 was defined as no pain, 1 to 2 defined mild pain, 4 to 6 moderate pain, and 8 to 10 defined severe pain. The total duration of the hospital stay was also noted, and the data compilation and statistical analysis was done. Next slide, please. Results. My results were more patients in the local anesthesia group had earlier pain relief with spinal anesthesia group. There were already 4 patients in the local anesthesia group who had reported no pain, and 6 hours after the surgery, while none in the spinal anesthesia group were pain-free at the same time period. None of the patients in the local anesthesia reported severe pain at 6 hours after surgery. However, in the spinal anesthesia group, they complained of comparatively more pain, and the majority were in the was 2 to 4, that is mild pain after 6 hours of surgery. Post-operative complications were most commonly noted among patients who underwent spinal anesthesia, with 5 patients having urinary retention and 2 patients having headache. The length of hospital stay was significantly less in local anesthesia compared to spinal anesthesia group. Next slide, please. My discussion with the emerging trend of day case surgery for inguinal hernia repair performed by general surgeons. Efficiency of a repair method is determined according to the low post-operative recurrence rate, the cost-effective, efficient character, and a low level of post-operative pain. With the use of local anesthetics, the need for cardiac evaluation and the fitness for older patients is not compulsory. Also, the patients can be discharged on the same day, thus adding to the cost efficiency of the use of local anesthesia. When the patient is admitted in the hospital, even the attendants, they have to stay in the hospital, which disturbs the family life. So with the use of local anesthesia, as it allows the patient to return to normal activities, family life is well settled. The recovery from anesthesia is also better for patients of local anesthesia group, as they were ambulatory immediately after surgery, thereby decreasing the risk of thromboembolism or the use of any low dose heparin or something. In terms of cost effectiveness, local anesthesia is better as it eliminates the need for an anesthetist, thus further reducing the cost, making it comparatively more effective and useful. The patient is free from complications of spinal anesthesia like urinary retention, post-dural puncture headache, hypotension, which is similar to the findings of Van et al. And previous studies. The post-operative pain is the most troublesome complication in open inguinal hernia repair, and our study shows that early post-operative pain is reduced when operation is performed under local infiltrative anesthesia. In the present study, mean post-operative hospital stay was less in local anesthesia group, which is in accordance to the result obtained by previous studies by Subramaniam et al., Nordin, and Goel et al. Next slide, please. Some sedation during the operation may be required for anxious patients, which loses the benefits of avoiding general anesthesia. And patients who are excessively nervous may be unsuitable for surgery under local anesthesia. Another drawback is that multiple pricks are given during local anesthesia infiltration. Although the pain sensation are blocked by local infiltration, traction on the tissues is uncomfortable for the patients. It can be concluded that inguinal hernia repair under local anesthesia is as safe as spinal anesthesia, with the benefits of less post-operative pain, less duration of hospital stay with no spinal anesthesia related complications. It is cost-effective and practical alternative to spinal anesthesia for fast-track ambulation of the patients, also better in old age groups and debilitating patients. Thank you.
Good presentation,
Open for
Rahul.
discussion. Yeah.
Yes. Rahul, a few things which I wanted to tell you about it. You told about bupivacaine, you told, but you never mentioned that what is the dosage of bupivacaine? You never mentioned.
Actually, sir, bupivacaine we didn't use in our local anesthesia infiltration, but it was used by the for spinal anesthesia, sir. So.
Okay. And what about randomization, Rahul? How did you randomize? What type of randomization did you do?
Randomization was, sir, whichever patient came to us, sir, we randomly divided them into either local anesthesia or like alternatively we took one patient we did we took for spinal anesthesia, the next we took local anesthesia, which however they were admitted, sir.
Okay.
So Yes, sir.
But in your study, you have not recorded what is the time of the surgery, or what time, what duration of the procedure. You have not told about it. Whether it was similar, whether
Like
it was more.
sir, we didn't compare the time duration of the surgery, sir. We didn't note that.
Oh.
Is there any, Dr. Rahul?
Yes, sir. Yes, sir.
Is there any problem when you are dissecting the sac after giving local and after spinal anesthesia? Is there any difference in your study?
No, no, sir. Just that few patients, they were uncomfortable with that stretching pain, sir. Stretching which they felt. Just that, sir.
What about
During
complications? What about complications?
Complications that we noted were in the local anesthesia group, sir. One patient had wound hematoma, sir, and one patient had testicular pain and swelling, sir. While in the spinal anesthesia group, sir, the old age like patients, they had urinary retentions. Five of them had urinary retentions, and two had headaches, sir. Postdural puncture headache mostly.
One thing is, in your slide, you mentioned that you don't have to evaluate a older patient for a cardiac fitness.
No, sir, I said we can avoid that if they're not very
better, but
affordable.
you have to evaluate the patient as for a general anesthesia only.
Yes,
but you
yes,
can
sir.
take him for under local anesthesia. The risk is
Yes.
less.
Yes,
But
sir.
evaluation, even in a daycare setting, you have to evaluate, or rather, not complete. Okay, remember
Right.
that.
Yes, sir. Yes, sir.
Daycare
Right.
means there is no shortcut. You have to evaluate the patient as per the
Yes.
regular general anesthesia or spinal anesthesia. But you
Okay, sir.
decide under if you want to go local, it's good. You can go ahead with the local. Okay.
Okay, sir.
Okay. Thank you.
Thank you, sir.
Any other questions? I think we can move on to the next speaker.
Yeah,
Is Dr. Prakyat here?
Hello.
Dr. Prakyat?
Yes, ma'am. I am there, ma'am. Am I audible, ma'am?
Yeah, your name is not there. Is it that Lenovo?
Yeah. That's that one.
I had to change your name. Yeah, right. I think we'll start with your presentation now. Okay.
Shall I start, ma'am?
Yes.
Yeah, my topic is clinical profile management and factors predicting mortality in abdominal stab injuries in a tertiary care hospital. Next slide, please. So introduction. Trauma is still the most frequent cause of death in the first 4 decades of life. The abdomen is the third most common injured region, with surgery required in about 25% of civilian cases. So penetrating injuries to the abdomen are commonly related to the interpersonal violence, and the distribution of injuries varies from person to person. The way patients are managed once they get to the hospital can influence the outcome of such injuries. The purpose of this study was to give an overview of the characteristics of patients presenting with abdominal stab injuries in our area and to try to identify a pattern of organ-specific injury that could influence the morbidity and mortality of our patient if such a pattern was present. Next slide, please. So my materials and methods were, this was a descriptive study of all abdominal stab injuries above 18 years admitted in surgical emergency room in Care Hospital, Mysore during the period of January 2020 to December 2020. The following clinical and demographic data were collected for each patient. The socio-demographic data which were collected was age, sex, residence, and the time of arrival to the casualty. So initial assessment of the patient was done using ABCD, that is airway and cervical spine control, breathing, circulation, dysfunction of the central nervous system, and exposure, which was followed by regional examination of the head and neck, chest, abdomen, extremities, and also back was done. So an initial determination of abdominal trauma type was made by through physical examination. We defined stability and hemodynamic status with revised trauma score. Next slide. So it consists of, we define reverse trauma score by the components are the Glasgow Coma Scale, systolic blood pressure, and the respiratory rate. So the degree of dysfunction in each parameter is scored from 0 to 4, and the revised trauma score is determined by adding each of the coded values together. Therefore, the RTS scores ranges from 0 to 12. Next slide. So 2 types of investigative data were analyzed. Laboratory investigations, which included the complete blood count, blood typing, and cross-matching, and the coagulation profile. Next, the radiographic investigations, plain chest X-ray, pelvic abdominal ultrasound, And in some cases, if the patients were stable, CT was done. So these were the results which I was computed, which includes patient characteristics. The age group mainly which we got was 18 to 30 years, and there was male preponderance. Next case. Next slide, please. So, and the wound location, which was mainly on the anterior abdominal wall, which presented almost 20%, and right flank was 18 and left flank was 12 among the 50. Next slide. So clinical presentation, mainly we got the patients who presented with hemorrhagic shock, which included 15 number of patients. And the next was peritonitis and evisceration of the bowel or any abdominal viscera. Next was abdominal pain, and non-specific complaints was the least. So time to arrival of at definitive care was asked, and within 1 to 6 hours, 39 patients presented to the casualty, and the least only 2 patients presented, which was more than 24 hours. Next slide. So initial treatment was, we had done laparotomy for 42 patients, and 8% were treated with non-operative and observation strategy. Next slide, please. So in laparotomy findings, in our institution, we got the most majority of the finding was multiple small bowel perforation, which included 22 number of patients. And the next one was mesenteric injuries. And the least one was urinary bladder injuries. And in 6%, there was no organ injury was found. So in this outcome, full recovery, there were 38 patients had full recovery, and we had to do repeat laparotomy in 1 patient, and we had sepsis in 7 cases, and only 4% resulted in death. So discussion. In our study, we did not separate patients by geographical location. We included both urban as well as rural. So why? Because in knowing the geographical implications of transporting injured patients to definitive care, our main concern was to evaluate how fast patients were assessed and identified for surgical treatment and transferred for definitive care. Next slide. So transport problems explains why there are so many patients with peritonitis. Theoretically, patients should be managed within golden 1 hour after injury. Patients with massive hemorrhage will die, and those who survive the initial insult will develop peritonitis. Our treatment modalities focused mostly on immediate operative treatment. In our series, we managed only 8 patients in non-operative fashion. Next slide. In our patients, the leading roles were played by the small bowel, colon, and stomach, except that liver and spleen were not the most damaged organs in the abdomen compared to blunt trauma injuries. So the overall mortality for the group of patients was only 8%, largely related to hemorrhagic shock. So conclusion, a number of independent risk factors for fatality were identified in the sequential sample of 50 abdominal stab cases presenting to our emergency department. This included patient characteristics, time to arrival at definitive care, wound location, clinical presentation, and laparotomy findings. So rapid emergency transport and rapid intervention should help to reduce the mortality in these patients.
Open for discussion.
Yeah, we have some of the questions in chat box. First one is it a prospective study or retrospective study?
It's a retrospective study, sir.
Retrospective.
Retrospective study, sir.
You did a retrospective study. Okay,
yes,
fine. What about the 6 patients? No, you said you did a conservative management.
Yes, sir.
On what basis you decided to do a conservative management?
Sir, we classified the patients whether they were hemodynamically stable or hemodynamically normal. So these patients were hemodynamically normal patients. So they had vital stables were their vitals were stable. So we decided to go with the further investigations. We admitted the patient. We got a CECT done, and then we decided whether to operate or not. And we found that there was no injuries to the abdominal viscera or any other major organs. So these were the non-operative patients.
Is there any breach of peritoneum in those 6 to 8 patients?
So in those 8 patients, only among them only 4 patients had breached peritoneum, but there was no any intra-abdominal major organ injury.
And you said about death, 4 patients have died.
Yes,
so can you enumerate, is it after surgery or before surgery or what?
It was, sir, I had previously in my results I had showed that 4 or 6 patients they had presented late to casualty. 2 patients had presented late to casualty after 24 hours of the initial insult. So they were they died because of post-operative. We had not operated the patient, so they were declared dead in the casualty.
But you said after laparotomy. Your study said after laparotomy, how many? 4 people died out of 50. So it was after laparotomy or before laparotomy? All the
After
4.
After laparotomy.
So what were the findings in that?
In those findings, we had one case. We had major vessel injury with we had a stab injury where the patient had presented the casualty with the dagger in situ. We had shifted the patient to the OT table with the dagger, and when we had opened, it was major aortic injury. So the patient actually died on the table. Sir.
What was the investigation you do once a stab injury patient comes?
Once
a stab is a factor here, you told me.
Time is a factor. We just ask we get a we classify the patient first actually, whether they're hemodynamically stable or unstable. For stable patients, we get a CCT and further investigations. And for unstable patient, we just get a complete blood count, preliminary USG, and just shift them to OT. Depending on
what is fast? What is fast? You do it there?
No, we don't do it in our setting. But fast is focused abdominal sonography for trauma.
Yeah. That is the line, right?
Yes, ma'am. That is the line, but it's actually not very sensitive for finding any intra-abdominal fluid. It is only sensitive if there is more than 100 ml of intra-abdominal fluid.
Yeah, but they are hemodynamically unstable, right?
If they are hemodynamically unstable, ma'am.
Yeah. That's where fast comes in, right?
Yes, ma'am.
So there is one more question in the chat box.
Yes, ma'am.
How do you manage the emergencies during COVID? How did you manage during COVID?
Sir, in COVID times, when these patients, actually we had patients of stab injuries during COVID times. So when these patients presented, we carried out the same regular investigations. But since we could not wait for RT-PCR reports, we just did a rat test and we then shifted them to OT for further management.
No other blood test done?
We followed every routine investigations except the one extra test was done was rapid antigen test for those patients.
Sir, any more questions?
No, ma'am.
No, ma'am.
Okay. Thank you. I think.
Thank you.
Thank you. We'll move on to the next presenter. That is, I think it is Dr. Ritika. Are you ready?
Yes, ma'am.
Yeah.
This is not.
Yeah, 1 minute. We are sharing the screen. Yes, your time starts now.
Good evening, everyone. Today, the topic of my paper presentation is a comparative study to assess the patient with acute appendicitis in a tertiary care hospital. Myself, presenter Dr. Ritika, second year PG student in JNMC Belgaum. Next slide. Acute appendicitis is one of the most common surgical emergencies in a clinical practice with an estimated lifetime prevalence of approximately 1 in 7. The diagnosis is primarily clinical and only contrast-enhanced CT is highly sensitive and specific for the right diagnosis. But because of the high cost and limited availability of sources, especially in the developing countries, there comes the problem. So there has been a need for a scoring system that can overcome these problems with acceptable sensitivity, specificity, and negative appendicectomy rate. Next slide. The modified Alvarado and the Repassa scoring system are the two important scoring systems that has been developed to aid in the rapid diagnosis of acute appendicitis. So we prospectively compared Repassa score with the modified Alvarado in 60 patients presenting with the right iliac fossa pain with suspected appendicitis in our institution. Next slide. The objective of my study is to reduce the negative appendicectomy rate by the effective diagnosis of acute appendicitis clinically and to reduce the wastage of the healthcare resources to improve the diagnostic accuracy and the delay in the diagnosis, which will further reduce the mortality and morbidity. Next slide. This is a prospective analytical study which is done in my department. The inclusion criteria is the patient above 18 years of age who are able to give consent for the surgery and who have been diagnosed and getting admitted for acute appendicitis in my institution. Next slide. Next slide, please. The exclusion criteria include patients who are not fit for the surgery, having previous history of urolithiasis, and patients who are not willing to give consent for the surgery. So the study period is 1 year and the sample size is 60. Can you hear me, ma'am?
Yeah, we can hear you.
Okay. According to the sample size calculation, the sample size came to be 45. So I have took 60 sample and both the scores were tallied accordingly to each case. Every year an average of 300 patients came for acute appendicitis. By the stratified random sampling, every third patient was selected. But due to the COVID, I have decreased my sample size from 100 to 60. So I've done over the 60 patient. Next slide. Next slide, please.
Yeah, it's ready.
So both the scoring system were applied in all the patient and scores were tallied accordingly. And the patient with the clinical diagnosis of appendicitis were taken for appendicectomy and the specimen was sent for the histopathological analysis, which is the gold standard investigation in my study, to calculate the sensitivity, specificity, positive predictive value and negative predictive value for each scoring system. And the statistical analysis tests were applied. The cutoff score for the Ripasa is more than 7.5 and that for the modified Alvarado is more than 7. So as we all know, the modified Alvarado scoring system, the total score is 10 with the higher preference given to the pain in the right lower quadrant and leukocytosis. Next slide. And then is the Ripasa scoring system. The total score is 17.5. Next slide, please. The next is the Ripasa scoring system in which the total calculation is 17.5. I've excluded the nationality, so the total score is 16.5. Here the age, gender, all are included in the study.
Disconnected. Disconnected. Internet is
Okay, 1 minute. It's disconnected. Hmm? Come. Yeah. Is it visible, Ritika?
Yes, ma'am.
Yeah, you can carry on.
Now the Ripasa scoring system in which the total score is 17.5, but the nationality non-Asians were not included, so 16.5. The higher preference was given to the guarding and the Rossing sign in these patients. Next slide, please. Yes, ma'am.
Yeah. Is this a slide or the next one?
It's the next slide only.
Results. Yeah. This one? Is this the slide, Ritika? Ritika, can you see the slide? Hello, Ritika, are you on? Hello. Did we lose her, sir?
We disconnected now.
I think she's disconnected. She's not there. The audio is gone.
Audio is muted.
She has muted, I think so.
Hello, ma'am.
Yeah,
Hello,
you have
ma'am.
muted yourself.
It's
Yeah.
ma'am. I was disconnected. Sorry, ma'am.
Yeah. You can carry on now fast. Yeah, you can carry on.
So this is the distribution of the study population according to the 28 were the male population.
She has a problem with her.
This is the distribution of the study population according to the age. So the patient who are less than 40 years of age were on the higher chunk in the study population than the patient who are more than 40 years of age. Next slide. This is the distribution of the study population according to the frequency of the signs and the symptoms. So in all the 60 patients, I'm able to see the pain in the right iliac foci is there, anorexia is there in 42 patients, and then fever is there. So this is the frequency as per the signs and the symptoms. Next slide. Next slide, please.
Yeah, come. There's a bit of a lag. Again, just go. That's not coming. Yeah.
So the gold standard criteria, which is the histological diagnosis. So the histological report which is sent, it came out that among the 60 patients, 52 were the candidates of the acute appendicitis, and 8 HPR came out to be grossly normal appendicitis, normal appendix. So as per the RIPASA, as you can see, the cutoff is more than 7.5. So higher chunk fall in that category. And in case of the modified Alvarado, that is able to diagnose less of the cases. So this is the comparison of the sensitivity specificity. So RIPASA is more sensitive and has a higher positive predictive value and accuracy as compared to modified Alvarado system. Next slide. Receiver operator curve graph has also been made, which is also showing the same thing. So in the modified Alvarado system, the area under the curve is 53%, and there is a specificity of 100%, and the cutoff value is came to be 4.5, which is lesser than the original cutoff, that is 7. And according to the RIPASA, the receiver operator curve is sensitivity is 95.6%, and the specificity is 80%. Next slide. So acute appendicitis can be challenging for surgeons because of appendicectomy delays and problem with the diagnostic accuracy. A delay in performing appendicectomy can further lead to many complications like perforation or any inflammatory mass. Moreover, the rate of negative appendicectomy is around 20 to 30%. So improving the diagnostic accuracy and reducing appendicectomy can be achieved through other diagnostic like CTs, but it will increase the overall health cost for the patient. Next slide. So in my present study, out of the 60 patients, 82 were the patients which are less than 40 years of age, and right iliac fossa pain came out to be statistically significant. And in modified Alvarado system, various parameters are also missing like age, gender, and duration of symptoms, which is also important as it is counted in the RIPASA system. Next slide. So RIPASA is a very simple system with a better sensitivity and specificity than modified Alvarado, and it consists of 14 parameters that can be obtained from a good clinical history, clinical examination history, and laboratory investigation. So as per my study, RIPASA score has a better sensitivity, specificity, and negative predictive value compared to the modified Alvarado score in general.
Paper is open for discussion, sir.
Yeah. Did you do an open appendicectomy or laparoscopic appendicectomy?
Sir, in my institution, only laparoscopic appendicectomy is done, sir.
Okay, but it was in COVID time, no?
Yes, sir, but we do lap only, sir.
Your anesthetists were giving laparoscopic appendicectomy during that time?
Yes, sir. The patient, we try to treat most of them by conservatively only, but the patient who are very unstable. So there is in the anesthetist, for the anesthetist, sir, there is a chamber which they have placed in the OTs. So they're doing very less now. Yes, sir.
Yeah,
To ease the contact, direct contact. So only
basically, sir is asking what are the precautions you have taken when you're doing a lap surgery or an open surgery during COVID?
Yes, sir. First is for the anesthetist, we have put that chamber to decrease the direct contact between the patient and the doctor. And as far as laparoscopy is concerned, the gases which are evacuated, they are through a special suction pump are there while we are deflating and in during the deflation. So minimizing aerosol contact, sir.
Okay.
Okay, I have a question, Ritika.
Yes, sir.
You have excluded patients less than 18 years. I want to know why, because 10 to 20 years is the age where you can see most incidents of appendicitis.
Yes, sir. Sir, as I'm doing a study, so I have to take a consent for that. So that's why, for the consent purpose, only above 18 years of age can give consent for the surgery by himself. So that's why I've excluded some.
And one more thing, you told that 8 number of patients had normal appendix, right, from HP.
Yes, sir.
But that accounts from 13% average, negative appendectomy rate. But you are telling it is 2%.
Sir, like in the Ripasa, sir, there are the total appendicitis which are there in the HPR report is 52, sir. But in my case, by the Ripasa, I have diagnosed 54 patients, sir, with appendicitis, sir. That's why.
No, man. Actually, you have to. You told histopathological examination is the gold standard.
Yes,
so, if at all, if in the study, if appendicitis is present in, in histopathological examination, that means that you have to correlate your score with the HP. So you cannot tell that that's a 2%. I think statistically it's not possible.
That calculation I have not done, sir. But by the Ripasa, they have misdiagnosed 2 cases, I can say.
And you need to know one more thing, that Ripasa is derived from the Alvarado scoring system and named as Ripasa. Okay. Thank you, ma'am. Thank you.
Thank you. Thank you, Ashrita. Ritika, we are moving on to the last paper of this session by Dr. Ashrita.
Hello,
Ashrita, you're on?
Yeah, ma'am. Am I audible?
Yes.
Good evening, everyone. I'm presenting a paper on role of Mannheim Peritonitis Index score in predicting the morbidity and mortality in patients with peritonitis secondary to hollow viscous perforation. Next slide. Introduction. Acute generalized peritonitis secondary to GI hollow viscous perforation is potentially a life-threatening condition, and its prognosis is usually poor. And grading the severity of acute peritonitis as assisted in decision-making, in evaluating new therapies, improving quality of care in severely ill patients. Next slide, ma'am. The previous slide. So there are many scoring systems which are designed for it. To name a few, there's Apache 2 score, Simplified Acute Physiology score, the Sepsis Severity score, Granson score, Imright score, and Mannheim Peritonitis Index, that is MPI. So this MPI was first developed by Vacha and Linder in 1983. Initially, there were 20 factors which were taken. Later, only 8 proved to have prognostic relevances. So those are the 8 factors which we are using in this study with the weightage. And it was used as it is a specific score. It has a good accuracy, easy to handle clinical parameters. It allows the prediction of the individual prognosis patients with peritonitis. And there are only few published Indian studies for this study using MPI. Hence, this present study was taken up. Aims and objectives. It is to predict the risk of morbidity and mortality in patients with peritonitis due to hollow viscous perforation and to evaluate the role of MPI scoring system in patients with peritonitis secondary to hollow viscous perforation, to use it as a clinical tool in assessing the severity. Next slide. This was a prospective observational study for 18 months. It was done from July 2019 to December 2020. The sample size taken was 50 at 95% confidence interval and 7% relative precision and 94% expected proportion. Area of study was Navodaya Medical College Hospital in Raichur. The inclusion criteria, the patients who presented to OPD with peritonitis secondary to hollow viscous perforation and all above 18 years, and patients below 18 years were excluded, and also the patients with primary peritonitis and peritonitis due to trauma were excluded. The preoperative work was done as usual, and MPI was applied on all patients, and the patients were divided into three groups according to the score, that was less than 15, 15 to 25, and more than 25. And all the patients were taken up for appropriate surgery and peritoneal lavage was given, and they were followed up till the outcome, which was either mortality, morbidity, or they were recovered and they were discharged. The results. The mortality was maximum in age group of more than 50 years, which accounted for 18.51%. In the table, we can see that in patients less than 30 years, only there was one death among 7 patients. And in between 30 to 50 years, all were cured and there was no death. And more than 50 years, there were 5 deaths in total of 27 patients. The mortality was more among patients with MPI score of more than 25. And the study saw a significant positive correlation between the increasing score and mortality, and the p-value was 0.027. The table shows that the score with less than 15, there were no deaths at all. And its score 15 to 25, there was only 1 death among 9 patients. And in more than 25 scoring, the death was 5. So it almost accounted to 83.3%. This shows that the people having more than 25 MPI score were almost 5 times more mortality compared to those who had score less than or equal to 25. Even the bar graph also showed the curative rates were better in score less than 50, and mortality rates were higher in patients more than 25 score. This is a table which is showing the other parameters and relating it to the mortality rates. Age already discussed. In sex, though the female patients were more, the male patients had more mortality rate compared to the females. And patients who presented with diffuse generalized peritonitis had more mortality rates compared to those who didn't. And when the exudates were clear, there was no mortality at all. But when they were cloudy, there were 6 deaths. And p-value was 0.01, which is significant. And when there was delay in diagnosis, that is preoperative diagnosis were more than 24 hours after presentation. So in such cases, the mortality rates were higher. And even when patients had organ failure, the mortality rates were higher. Next slide. So mortality was significantly associated with the people with aged more than 50 years in males and patients with diffuse generalized peritonitis, and when there was a delay in diagnosis, and when the exudates were cloudy, and in patients with organ failure. The sensitivity and specificity of the index score. For a score of 26, the sensitivity was 83.3%, specificity was 95.54%, the positive predictive value was 92%, and accuracy of the test was 94%. Next slide. Discussion. Peritonitis secondary to hollow viscous perforation is one of the most common cause for emergency surgery, and there are various factors as discussed above which influence this. And there are many studies, the few studies which are done, which shows that MPI is an independent, objective, and effective scoring system. And few studies like Billing A et al., the study showed that people with a score of less than 21 had 0 to 2.3% mortality, and between 21 to 29 had 65% mortality. And Notash, Ava et al. Study, they took the scoring system to be less than 21, 21 to 29, and more than 29, which showed that mortality of 60% in people having scored 21 to 29, and almost 100% in people having scored more than 29. These are also similar studies. All studies almost show that higher the score, the higher is the mortality rate. And also the delay in the diagnosis leads to higher mortality. It was the same even in our study. Conclusion, increasing score of MPI indicated bad prognosis. Higher the score, higher is the mortality. And the association, other factors which were associated with it, like age, sex, exudates, delay of diagnosis, and organ failure. So patients who are having high score need close monitoring, close attention, and monitoring of the vitals. Then MPI is a disease-specific, easy to interpret in predicting the morbidity and mortality in patients with peritonitis secondary to hollow viscous perforation. Thank you.
Thank you, Ashrita. So 1 minute for discussion.
Yes, ma'am. What is the most common cause for a perforation in your study?
So duodenal perforations were seem to have the most this thing. So we had almost 26 people having duodenal perforation, and then followed by appendix.
Followed by appendicular perforation.
Yeah.
Okay. Did air was there under X-ray in appendicular perforation?
In few we had appendicular perforation X-rays, but in few we actually were suspecting it to be, they had history like recurrent appendicitis. So we were just having a view of like recurrent appendicitis. We operated for them, but peritonitis had developed just before the OT. They had diffuse pain and stuff. So there was no air under X-ray. It was an intra-op finding.
Okay, okay, fine. What is the cause of death in that one patient who has died less than 30 years?
Sir, it was a cardiogenic shock, sir.
No, I'm not asking that. What is the cause? What was the perforation? He had a duodenal perforation or appendicular perforation?
No, he had appendicular perforation, sir. It was almost necrosed and gone.
Okay.
It was an intra-op finding.
No, what you did for that?
Actually, we opened thinking it might be recurrent appendicitis. But on seeing the tip of the appendix was perforated, and he had history of like recurrent appendicitis previously. So we just had to take out the appendix, and no resection was done, just closure was done, sir.
Means your base was healthy, so you ligated the appendicular base.
Yeah,
And, is there
base
any
was healthy, only the
much
tip.
contamination or localized peritonitis?
It was localized peritonitis, sir.
Hello?
Hello? Can you hear me, sir?
Hello?
Hello?
Yeah.
Yes, sir. Yeah, you're audible.
Yeah. She is not audible.
Hello.
No, she's listening, sir. Yeah, Ashrita, can you hear?
Yes, ma'am. Am I
I
audible?
just wanted to know that one patient, because he's a young patient, no 30 years. You said only
Yes,
tip is
sir.
gangrenous. Did you,
Yes,
like,
sir.
base was healthy, like cecum was healthy, everything was healthy. Is there any contamination, bad contamination, or just was it?
He didn't seem to have bad contamination, sir. The surgery also was fine, but later he had like almost all his vitals started coming down. So we thought it might.
Okay, fine.
Okay, thank you.
Thank you.
Thank you. We have come to the end of this session of free papers. I'd like to thank our chairpersons, Dr. Suresh Badigar and Dr. Bharat, for this excellent conducting of the session, sir. Thank you very much.
I thank the organizers. Yes, ma'am. I thank
Thank you,
Dr.
sir.
Aruna, and I thank the organizers of Kscasicon 2021 for giving me this opportunity. Thank you very much, ma'am.
Thank you so much, sir.
Thank you.
Thank you all the participants. I think we are going on to the next session. That is the recent advances. Is Dr. Chetan Hoskati here? Dr. Chetan Hoskati, who is going to talk on platelet-rich plasma in chronic ulcers. How good is it? Is he here? We don't see him in the chat box. I think I'm seeing Dr. Subramanieshwar Rao here. Sir, welcome, sir. Sir, you can unmute. No, not sir. No. This one. Yeah. I think. We'd like to invite Dr. Raja H as the chairperson for this session of recent advances. Welcome, sir, Dr. Raja.
Thank you, ma'am. Welcome. Welcome, sir, Dr. Subramanieshwar.
Am I speaking? Hello.
Yes, sir, you're audible now. You're audible now, and we have made you a co-host.
Okay. Can I share my screen? Because Dr. Divakar wanted me to speak from my laptop.
1 minute, sir. I'll just check out.
Yeah, please.
Yeah. Your co-host. No, not that. Not that. Listen. Yeah.
But host has disabled participant screen sharing, it says.
No, yeah, sir. You are, yeah. 1 minute. Just see.
Co-host.
He's a co-host. Yes, sir. You are the co-host for this. You can share your screen now.
Okay. Can you see the screen, madam? No?
No, sir. No, sir. It's not this.
Done now? Yes, madam?
Yes, sir. We can see your screen and you can start your presentation.
Thank you very much, the office bearers and the organizers of Kscasicon for my presence here this evening. I would be talking about robotics in abdominal surgery. I've retitled it as Hope or Hype. I declare no conflict of interest. They're all my opinions, and I respect others' opinions as much as I respect my own. If you look at the basics of robotics in surgery are self-powered computer-controlled devices that can be programmed to aid in the positioning and manipulation of surgical instruments. The parts are a master console and then master manipulators, the robotic arms, and the instruments with an endo-wrist. The advertised merits of robots are something that we need to discuss. There is a continuous discussion that laparoscopy remains 2D, whereas the robot is 3D. We understand robot started as 3D and continues as 3D, but now there is enough 3D instrumentation that we can see all over. And then the counterintuitive movement that we talk about, while the laparoscopy was being developed, counterintuition was a problem because we didn't understand the port positioning and in relation to the telescope. It's not a problem anymore. Unstable camera in lab, the camera stays stable. Next. Less degrees of freedom is something that
new adjuvant
should be
CTRT
accepted.
Positive air leak test and increased number of staplers fired. Usually,
I'm hearing somebody else speak. Surgeon uncomfortable in laparoscopy. Surgeon is standing in laparoscopy, not necessarily uncomfortable. And then you talk about the learning curve differences. If you have to bust these myths, laparoscopy is not 2D anymore. There is 3D, and over that there is 4K, which has much more immaculate visuals than the robotics. Counterintuitive movements were a problem initially before we understood the ports and their positions. Unstable camera is stable, but the instrumentation at the table can be unstable. Less degrees of freedom is something that we need to accept. It's a more genuine advantage of robotics. And surgeon uncomfortable in laparoscopy. If the surgeon is uncomfortable in standing for a long time, this also needs to be agreed. Learning curve is debatable. Both of them take a long time to learn. And then while you are seeing, we keep talking about the goggles. I don't know, I've never thought that goggles cause so much of disturbance. And you in fact peep into goggles here, not as if there are no goggles here. Here you are carrying the goggles. Here the goggles are with the console, and the problem is with this position, the neck pain is much more in robotics than in laparoscopy. The shoulder, the knee joint issues are much more with laparoscopy. Counterintuition, when we talk about, if you are looking at the camera in a 180 degrees angle, the instrument is going just opposite the telescope, that is when counterintuition comes into play. And that doesn't happen while we are hitting the target organ. It happens when there are adhesions, because we don't insert ports for the adhesions. So adhesions are always a surprise, and we cannot put too many ports just to get the adhesions out. That's where counterintuition actually works. To the level of discomfort, it's a very rare phenomenon. And especially if you don't do too many re-explorations or re-laparoscopies, I think this is not a very serious problem. It's a very small percentage, and it can be surmounted with a bit of experience. It looks like a simple problem, but counterintuition, especially when you are looking straight into the camera, if it is anything less than 180 degrees, it's very comfortable. We just wanted to pick this up. You know you are just there, but your movements are mirror image, so it can be difficult. Even for an expert, this movement can be difficult. So this is something that has been highlighted in a very, very big way. When your hand moves to the left, if the instrument tip moves to the right, that is not actually counterintuition. This is true counterintuition, which can cause discomfort and which is a very rare phenomenon. Human brain, we must understand, the counterintuition that is projected against laparoscopy, human brain is actually intuitive and counterintuitive. It actually picks up both these movements. And if we keep discussing about wristed instruments, they do have their own problems apart from their expenditure. And what is important is the three instruments that are there need to be in the field all the time. And once you lose them, you need to go to the patient cart and then correct it. And sometimes I can see that the scissors, the hot shears is lost. It's a very sharp instrument, and any movement there can cut anything that is on its way. So you have problems there. You can see an instrument that has malfunctioned here. The third use, it started malfunctioning. It was moving autonomously without any control from the surgeon. So if you have lost it, you have lost seven of its uses after this. So not everything is hunky-dory, not everything is rosy. There are problems even in laparoscopy. We've got it after a minute of searching and from the patient cart movement. So these are things that need to be learned. Surgeons would be a little more comfortable, especially if you prefer to sit down and operate. We accept that, but there are a maximum of 3 instruments. One of them, the third arm, is used to apply traction on the uterus. And the other 2 arms, if you have to go deeper, I would need to leave this. So an assistant trocar is necessary. And the arms hovering on the patient's abdomen, there is very little space for the assistant. The surgeon is very comfortable, but the rest of the team stays uncomfortable for more than one reason. They have to bend into the under the arms, and arms keep hitting them. And you can actually see an assistant instrument from the assistant trocar coming in, trying to occupy the same space, and it's actually moving this instrument away. There is pressure on the vessels here, multiple attempts. These are 12 mm trocar that we use for gauze for suction and things like that. So this discomfort can be there, and you cannot be using too many assistant trocars. So the instrument had to be taken off, and we had to continue dissection like this. So the assistant is uncomfortable because they keep looking at the 2D screen, which is never of a resolution compared to any laparoscopy. So there is a discomfort here again. You would be sitting like that and then peeping into. We keep hearing that software employees burn out very rapidly because of their position and their vision into the screen. So there is discomfort even in robotics. And we should also understand that it's always good to be a good conventional laparoscopic surgeon to be comfortable in robotic surgery, because you can get into such situations which may be completely off the target as far as robotic is concerned. Robotic is very comfortable in a single field. So we may need to do this by laparoscopy and then dock the robo, that is the robotic trocar, and then go ahead. So you need to be a laparoscopic surgeon irrespective. The true advantage is the wristed instrument. You can actually see here that a straight instrument there, straight stick instrument, lots of struggle while it cuts very close to the trocar ipsilaterally. Whereas the robotic instruments move very elegantly in doing these procedures. This is a distinct advantage. If you're looking at indications, robotic is not new, 25 years in the making. The real standard indications are, one is non-abdominal and the other one is abdominal but pelvis. A partial nephrectomy is also a bit of an indication. These things still remain in the domain of more laparoscopy than robotics. So if you look at evidence, it seems to be a solution in search of a problem. Robotic surgery is an example of when newer is not always better, but clearly more expensive. There are multiple trials that have come in various organ systems. If you look at the ROLA trial, the colorectal trial, laparoscopy seems to be equivalent, except in conversion. Once again, in a male patient, obese patient, narrow pelvis, robo helped a little bit. Health economics, if you are looking at, it costs 980 pounds or over $1,000 more in robotics when compared to robot trial. Minimally invasive thoracolaparoscopic esophageectomy versus open esophageectomy. The pain has been reduced, pulmonary cardiac complications compared to open, but oncologically both seem to be equally safe. What is surprising is the most hyped indication, the radical prostatectomy, and the urinary sexual outcomes at 2 years, there was no difference in a randomized study. In radical cystectomy, compared to robotic versus laparoscopic, the outcomes seem to be once again similar. Parodic implanectomy in endometrial cancer, robotic assisted versus laparotomy, once again, the lymph node yield was all same. The operating time in robot was longer, but with a shorter stay, compensating for the money saved in shorter stay. In the West, each day stay is extremely expensive. This is something that compensates for the costs of robots. But in an Indian scenario, even if they stay a week longer, Indian hospitals are never as expensive as a robot. The demerits are space and time consuming. It burdens the physical and burdening physical maintenance aside from cost. Hybrid procedures. Every robotic procedure is a laparoscopy assisted one, not vice versa. And there is absolute reliance on biomedical engineers. There is no tactile feedback. The assistant surgeon's arm twisting that I talked about, and frequent troubleshooting with the instruments that is necessary. And the cost is not just acquisition plus and consumables, but also annual maintenance, which is extremely expensive. Drawing an analogy to the Concorde planes that were launched in the 80s and 90s, it would do New York to London in 3 hours, as against 7 hours for the regular Boeing and the Airbus. Amazing technology, but had to be discontinued due to high marginal cost. Is the robotic system really better than the 3-dimensional laparoscopy system? A study says that novices benefited particularly from the robo. The intermediate group completed the task equally well, whereas the experts actually did much better with the 3D laparoscopy when compared to the robots. The advantages of 3D laparoscopy are expertise is more freely available, affordable, universal, less time consuming, similar short-term benefits of minimal access surgery. Training and learning curve is very short, and what is needed is an endo-risk capability for the 3D laparoscopy, and that seems to be on the horizon. The two major indications are radical prostatectomy and partial nephrectomy, which are single field operations which require suturing in corners and crevices. We talk about low rectal resections and ability to suture, but once you learn, you can see an elderly male patient with such a narrow pelvis, an anterior resection being done with an intracorporeal anastomosis, We have done 33 of these in the past 1 year without failure to being able to anastomose even in one patient. So this is something that is achievable with both, only if you think you can achieve it. So what is important here, I would say, is this stitch is something that I'm doing with my left hand. So you may need to equalize the skill, nearly equalize the skill with your left hand if you want to avoid all the expenditure of the robotics. The way forward is democratizing the robots. It should not be one company and monopoly. There are quite a few companies that have come into the Indian market again. And what if this hits the operation rooms? I think this is something that is handheld wristed instrument called the Flex Desk. It is in the process of fine tuning. So once this happens, it becomes much cheaper, multiple uses. That's how it works. You mount it onto your hand and it becomes a wristed instrument. So it becomes a robotic arm in laparoscopic surgery. Ergonomics should be balanced against economics. Anyone who thinks they have a monopoly on truth and there is only one way to see the world always gets us into trouble. So I would call it a hype because it's not a new technology, it's 25-year-old. There is no clear evidence of superiority, oncological or otherwise, and the prohibitive costs that continue to happen. We hope that we have disruptive technology in this. We need to continue into robotics. We hope we have technology to aid patients maximally, not marginally. We hope we have technology to universalize treatment. We hope we can afford to pay for the technology. We hope the data steers us in the right direction. And we hope to be called surgeons, not related to any company, not a Da Vinci surgeon, but a surgeon who's skilled in robotic usage of robotic assisted laparoscopic surgery. Hope our my generation lives long to see all the progress, and hope my patients won't cause this discomfort for me, saying that the robot needs to be paid and not me. Value is always quality or outcomes divided by cost. When the cost goes up, even if the quality improves marginally, the value drops down. Surgery is more of an art than a science. The best surgeons, armed with the best technology that they are comfortable with, will achieve the best outcomes for their patients. So if you are a very good laparoscopic surgeon, you would not need a robo. For the best, laparoscopy is just as good. For the rest, I think robo can add. And if you are as talented as this Indian simple brick worker, I think if your skill is as good as this, laparoscopy is something that will stay in your armamentarium without taxing the patient with any amount of money that he needs to pay extra for the machines that we are piping and actually selling. If Da Vinci was born in Kolkata, he would have been called Vincida. Thank you very much.
Thank you, sir. That was an excellent presentation, a very lucid one at that, about robotics. That is Dr. Subramanieshwar Rao from Indo-American Cancer Hospital, Hyderabad for us. Thank you, sir, for joining us. It was a pleasure hearing you.
Thank you very much for the opportunity, madam.
Thank you, sir. Thank you, sir. We are moving on to the next presentation in recent advances. That is Dr. Chetan Hoskatia. Are you ready?
Yes, ma'am, I'm ready.
Yeah. We'll be screen sharing your this one.
Ma'am, my presentation is there with.
Yeah, we are sharing it. No, not that. Not. Yeah, you can see it.
Not yet, ma'am. Yeah, now I can see it.
Yeah, 1 minute. We'll start from the beginning. Start from the. No, not that. Not that. Yeah.
Stop share करनी है. I think that has been shared. Yes. No.
Yeah, can you see the screen?
Yes, ma'am, I can see.
Yeah, we have Dr. Chetan Hoskati here. He's a vascular and endovascular surgeon from Ramaya Medical College. Yeah, you can start now.
Yeah. Good evening, everyone. I thank the organizing committee for giving this opportunity. Today, I'll be speaking about platelet-rich plasma in chronic ulcer. How good is it? So, next slide. So, all wounds go through basically 4 phases of healing, that is hemostasis, inflammatory, proliferative, and remodeling. Basically, the duration of each phase depends on the underlying pathological factors like venous insufficiency, diabetes, or ischemia, or inflammatory conditions, and immunocompromised patients. And most of the ulcers turn into chronic when one of these underlying pathologies are present. So when we call it a chronic ulcer when the ulcer doesn't show any signs of healing, even after 6 weeks of starting treatment, or it doesn't show any signs of healing, or it doesn't heal. So the chronic ulcer are characterized by bacterial colonization, tissue hypoxia, and prolonged inflammatory phase. Due to this, there is a large amount of proteolytic enzymes which are present in these wounds. And there is reduced growth factors and reduced fibrin content. So the basic idea in treating these chronic ulcer is to reduce the inflammatory phase by adding the growth factors, and also by taking care of the underlying condition. So these platelet-rich plasma is the basic mechanism of this is whenever there is an injury, we all know that the platelets accumulate over there and they get activated, and they release cytokines, chemokines. Previous slide, please. They release cytokines, chemokines, and adhesive proteins, and they in turn activate these growth factors, which ultimately lead to angiogenesis, proliferation, and ultimately wound healing. So this forms the biological basis of using a platelet-rich plasma in treatment of chronic ulcers. Next slide. Next slide, please. Next slide. Yeah, this platelet-rich plasma can be easily obtained in our outclinic hospitals and in our OPDs by there are various commercial kits available where about 10 cc of patients' venous blood is drawn, and it is centrifuged, and in special pipettes which are the facial tubes which are available. And after centrifugation, we get different layers and various other blood products. And once the platelet-rich plasma is separated, it is separated from the other blood products, and it can be applied to the patient. Next slide. So the application can be in the form of intralesional or topical. Intralesional will be around the wounds and topical on the wound. But before application of platelet-rich plasma, we have to be sure that there is no infection and there is no slough. If there is any infection, we have to clear it, and if there is slough, the debridement has to be done. And we also have to rule out malignancy. And topical application of platelet-rich plasma can be done in the form of gelatin base, which also comes in that commercial kit. And before doing all this, it is also important to take care of the underlying cause. And the application can be done on weekly basis over the 4 to 12 weeks. And also the conventional treatment can be combined with application of this platelet-rich plasma. Next slide, please. So I have accumulated various studies like case series and cohort studies. The basic topic for today is how good is this platelet-rich plasma. So numerous studies have been done where the cohort studies and case series and meta-analysis have been done, and they have included various kind of ulcers from diabetic, arterial, venous, neuropathic, and ischemic ulcers. And in next slide. These are the randomized control trials, again, which have included various studies. I'll just tell the gist of all these studies. It basically, the platelet-rich plasma has been shown that it has a beneficial effect on all the ulcers. But however, in case series on venous ulcers, it has been shown beneficial. But however, the randomized control trials have not shown any benefit over the venous ulcers. However, in diabetic foot ulcers, even randomized control trials and case series have shown a beneficial effect. Next slide, please. But the basic drawback of all these studies is the heterogeneous group of these patients, because of the different various types of ulcers and characteristics of the patient. There are several limitations to the studies, and there is no long-term follow-up for these studies. And also the sample size was quite small. These are also some review studies I have highlighted here, which have all shown that there is beneficial effect of platelet-rich plasma in diabetic foot ulcers. Other than that, in venous ulcers and arterial ulcers or trophic or other vasculitic ulcers, there was no much benefit seen with this platelet-rich plasma. Next slide. Coming to the one of the recent studies, which has included some of the very good clinical trials. These were 10 clinical trials which were included in this with 442 patients, and various etiology of ulcers were included in this. And there were different outcome variables were studied. And ultimately, this also showed that there is clinical benefit in diabetic foot ulcers only. And there was no beneficial effect seen in either venous ulcer or ischemic ulcers. So, but however, there is no clinical protocol developed yet for developing for application of this platelet-rich plasma. Next slide. So, as a vascular surgeon, I see various type of chronic ulcers, a lot of chronic ulcers in my day-to-day practice. My take is that whenever you are treating a chronic ulcer, always try to find out the cause for it. Unless you try to find out the cause and treat it, there is no point in application of platelet-rich plasma or any other kind of treatment. So whenever you find if there is a venous ulcer, try to find out whether it is a post-thrombotic limb or a varicose vein. If it is a varicose vein, in the form of varicose vein surgery, we can treat it. If it is a post-thrombotic limb, you can treat it in the form of stenting. If it is arterial ischemia, then revascularization. If it is a diabetic foot, then probably offloading and debridement are the best options, along with local wound care. Next slide, please. Next slide, please.
Yeah. 1 minute.
Yeah. To conclude, treating a chronic ulcer, there is a lot of dedication required from a treating physician as well as a patient. Patient also need to be equally educated, and he need to be compliant for this for treatment of any chronic ulcer. And treating the cause is of more prime importance. PRP topic today is a viable alternative. However, still it lacks a strong evidence. In my personal opinion, I have used it in about 5 or 6 patients in my clinic. It has shown some improvement in diabetic foot ulcers, but I usually don't use it in venous ulcers and arterial ulcers. And the clinical protocols for how to apply this platelet-rich plasma, how much interval is required, what is the dosage required, and what is the duration which has to be used is not yet been proven. So you have to develop your own protocol, and depending on how good is the wound healing along with platelet-rich plasma and treating the underlying cause, you can develop your own protocols. Next slide. Thank you.
Thank you, sir.
Thank you.
That was a very excellent presentation, sir.
Thank you.
Raja, sir, you have any comments?
Yes, sir. A very nice presentation. Was quite useful. Just one question. Do you need a special instrument or machine to prepare this?
One centrifugal machine is required, sir, which is usually used in pathology labs, which is about 3,500 RPMs. And usually the person whoever provides these commercial kits also, they get this centrifugal machine with them. So the same centrifugal machine, there are actually two methods of double centrifugation and single centrifugation. And double centrifugation is slightly a complex method, but however, single centrifugation method can also be used with equal effectiveness. A special instrument is required. Basically, that centrifugal machine is the one which is required.
Okay, sir. And how many sittings do you do for a chronic ulcer? Do you apply it once or twice or twice?
That's what still there are no protocols which have been developed. But however, it depends on how how the ulcer is healing. Usually, I do it once in a week, the 1 week duration, and it depends on how good that ulcer is responding to the this PRP treatment. If it is responding well, I go for another sitting.
Okay.
Okay, sir. Thank you very much, Chetan, sir. We are going to move on to the next session on recent advances. That is by none other than Dr. G.V. Rao, who's going to speak on when to use endoscopic ultrasound in GI surgery. G.V. Rao, sir.
Hi.
So we have made you a co-host. I think you can screen share your topic. Dr. G.V. Rao, sir, is a Director-in-Chief of Gastrointestinal and Minimally Invasive Surgery from Asian Institute of Gastroenterology, Hyderabad. It's an honor, sir, to have you here.
Thank you. At the outset, let me thank the entire executive for giving me this opportunity. I was made to understand that I'm supposed to talk on the use of endoscopic ultrasound, what the use of endoscopic ultrasound, what is the importance of endoscopic ultrasound in current day GI practice. Thank you so much once again, the entire executive, and especially my friend, Dr. Sopimat. Thank you so much, Dr. Sopimat, for this honor. Now, I'll just cover a couple of topics. What is it? How different is it from the other endoscopies? Has it made any different in current practice? And what are the applications of this? Basically, endoscopic ultrasound means you're combining endoscopy and ultrasound that becomes endoscopic ultrasound. You're integrating an ultrasound equipment into endoscope, enabling you to see beyond the GI tract. So basically, what you're seeing on the left side is what you're seeing on the luminal side. And when you attach an endoscopic ultrasound, you see beyond the gut wall. This is what it means by talking about endoscopic ultrasound. There are two types of machines that are available, a radial ultrasound and a linear ultrasound. Basically, just to show what's the difference between these two machines. Basically, initially, there was a lot of use of this radial machine, but with the current advanced usage of endoscopic ultrasound and more interventions being done, if at all somebody is using it, actually, I think only a linear ultrasound, endoscopic ultrasound, what is to be used right now, because it can be used in a wide variety of applications. Now, it's got both diagnostic and with increasing use, it's got therapeutic applications used in CVD stone, chronic pancreatitis, pancreatic tumors, GI wall lesions like any lumps or bumps that we see on cross-sectional imaging or even during diagnostic endoscopy. These are the usual layers. Once we start talking about endoscopic ultrasound, we start talking about the mucosal interface, muscularis mucosa, submucosa, muscularis propria, serosa. This is very important to know, basically, because entire management seems to be to see, especially when you're starting therapeutic applications, to see from which layer it is arising, the lesion is arising from, and whether it can be done endoscopically or it should not be done endoscopically. So just to give you a couple of examples, this is an example showing a transesophageal ultrasound showing a lymph node which was not picked up any conventional imaging, and this subsequently underwent an aspiration biopsy, showed to be tuberculosis. This is an incidental subepithelial lesion. Routine endoscopy showed a bulge here, and you can see this. Then we put an endoscopic ultrasound, you see a large duplication cyst here, which would be very difficult. Even cross-sectional imaging does pick up this thing, but differentiating between other forms of cyst becomes very, very difficult. This is another patient, a patient with gallstones who presented with abdominal pain and abdominal LFT, and MRCP did not pick up any stone in the bile duct. And again, you see an endoscopic ultrasound, it picks up small stones. Endoscopic ultrasound seems to be much more sensitive to pick up sludge and very small stones in the bile duct as compared to MRCP. This is another patient with recurrent acute pancreatitis, And you can see this endoscopic ultrasound is one of the modalities which picks up early chronic pancreatitis, and we have grades by which we grade early chronic pancreatitis. So early chronic pancreatitis can be picked up in endoscopic ultrasound as compared to any other modality. Again, the pancreatic head mass, which is, we have a good cross-sectional imaging. I'm sure good pancreas protocol CT is good enough. But again, pick up especially the venous involvement, and if you have a good endocrinologist who can give you a color Doppler, you can see this, the venous Doppler, the arterial Dopplers are very, very important, which the information which we not get on conventional cross-sectional imaging. As far as interventional and side is concerned, actually there are several interventions that are done either for tissue acquisition or for internal drainage of some of the collections that we see. And of late, we started doing vascular interventions, gastrojejunostomies, celiac neurolysis, and tumor ablation. We started as late as 2016. Just to give you a couple of examples, there are umpteen number of ways we can acquire a tissue biopsy, which is not possible in conventional modalities here. You either can do a fine needle aspiration biopsy or a fine needle core biopsies. Core biopsies are becoming more and more popular. Actually, you can see this is just a cartoon to show you how you get good amount of tissue. This is a thing that is totally different from the conventional true-cut biopsy that we see. The UVS true-cut biopsy is totally different, and we get fair amount of material in this whenever we're taking a biopsy. Pancreatic fluid collections, more and more of these fluid collections are being drained endoscopically now. This actually, we have two types of collections that we see. Either we see pseudocysts, wherein there is no debris in this, means acute pancreatitis, 4 weeks subsequently, if you're seeing, actually you have these collections. If there is no debris, it means it's a pancreatic pseudocyst. But if you're seeing any debris like this, it means it's a walled-up pancreatic necrosis. So most of these pseudocysts actually right now are being drained endoscopically, especially those pseudocysts which are in good approximation to the stomach and duodenum. The biggest advantage seems to be they improve localization. Visualization and avoiding interposing vessels is very clear. The best point of entry can be absolutely localized, and we're able to puncture even non-bulging collections using an endoscopic ultrasound. Just to show you a couple of examples as to how to go about these things actually. So basically, whenever you're doing, this is one of the commonest thing that is done. You check for the maturity of the wall, the content, you make sure that the liquid or solid, dimensions, the wall thickness, the scope position, check for any intermittent results and check the selective point. And then subsequently you puncture with a 90 gauge needle. These are the various needles that are available. Aspirate and inspect the fluid, send it for analysis and avoid any contrast injection into this thing. And once you have done this, a guide wire is passed to this 19 gauge needle. Make 1 or 2 loops into the thing so that you don't slip out. And once you've done this, there is a mechanical way of getting into the thing, or an electrocautery is used to make this tract into this pseudocyst. And once you've done this, this tract is dilated with the CRE balloon dilator to about 1.5 to 2 centimeters. And once this is dilated to 1.5 to 2 centimeters, subsequently you put a plastic stent in case of a pseudocyst. A double pigtail stent is put into the cyst cavity so that the entire fluid can be drained into the stomach. Now, especially when you have walled-up necrosis, this is a more labor-intensive procedure, high-risk procedure associated with some complications. But again, initially we used to do it with conventional dilatation, but now large caliber metallic stents have come, which are introduced initially. There are various types of lumen opposing stents that have come into clinical practice. What are usually practiced are the Axios or the Nagy stent. Actually, these are biflange stents. Now, the biggest advantage is these oppose the lumens actually. The tendency of any bleeding that happens at the gut wall is minimal. You can see this is how you deploy the stents actually between the walled off necrosis and the stomach. And once this is decreased, actually we see that most of the walled off necrosis, the liquid component can be very effectively drained off by this. And a small amount of debris spontaneously comes out of this stent. You can see this is how it is deployed. Now this is what happens actually. This is the wall of pancreatic necrosis. 4 weeks later, you can see that if it is just small amount of debris, the entire thing gets drained, and then 4 weeks later, we just simply remove the stent. Sometimes we have this necrosis that tends to block the thing. Actually, we use instruments to unclog the stent, and patients seem to do well. You can see this is how you unclog the stent. And suppose if it is still there, we put in a nasocystic drain, nasocavity drain, and irrigate this with saline or hydrogen peroxide. Very rarely now, less than about 10 to 15% of the time, we may have to go in with a scope into the retroperitoneal area and do this debridement like what we do in surgery. So majority of the ones which have limited amount of debris can be very effectively tackled just by putting in the stent, or maybe use some sort of declogging device or putting in a nasocystic or a nasocystic drain to irrigate the cavity. Now of late, we have started using this newer trend that have come. These are called as hot axios, which is a single step instrument that is used to make an entry point, at the same time makes a very effective burn into the wall of necrosis and subsequently deploys the entire stent. So this is a single instrument that is used as compared to what we are using actually. So entire procedure can be completed using a single accessory like this. And we have different stents that have come into the market right now. The biggest advantages of these are they're easy to deploy, large diameter for efficient drainage. They cover to prevent any leaks and perforation. They're self-expandable, and the design is such that they reduce the migration chances, and the reintervention through the stent are easily possible. Now, this is what I talked about. So you have to do a necrosectomy because this opens to almost about 1.5 to 2 centimeters. You can go very easily into the wall of necrosis and do the debridement very effectively. But again, these are indicated only in wall of necrosis that are in good approximation to the stomach or duodenum. But all wall of necrosis which are away from the stomach should not be dealt with endoscopically, should be dealt with surgically or percutaneous or the retroperitoneal approaches. Use guided biliary drainage, another new frontier in this actually. Now, what has happened was actually initially there are a lot of failed ERCPs. Actually, if we are not able to cannulate, initially we used to go for percutaneous techniques, but now endoscopic ultrasound has advanced. Right now, we have various means to access into the bile duct from the endoscopic ultrasound. You can directly gain an access into the bile duct or into the left duct, depending on the expertise of the people available here. This is one such example. You can see that when we are not able to pass into the thing because of the duodenal obstruction, you're gaining access directly into the bile duct here. So you're putting a stent directly into the bile duct, not through the papilla, but directly from the D1 into the bile duct. So this is a big advance in the field of endoscopic ultrasound. And likewise, if you see, this is more and more of these patients. Initially, we use hilar obstructions. These people used to go for some sort of segmental 3 bypass. Most of the GI surgeons were used to this procedure. But with the advent of this drain that is they're putting a lumen opposing stent between the left lobe of the liver, the segment 3, and the stomach. This is what is called the hepatogastroscopy now. Lumen opposing stents are being put. With the advent of this and other metallic stents, actually the segment 3 bypass that we used to talk about is almost gone to oblivion. We no more do these procedures. Like just to show you the examples as to how it is done in even a post-operative stomach where you're not able to get in because of the regular anatomy, because of the Bill-Rotto gastrectomy, we are able to get in and put in drains into the liver. US-guided gastrojejunostomy is one of the new terrains actually now compared to the conventional gastrojejunostomy. This is how they're putting in a lumen opposing stent. This is not, it is an upcoming field. I'm not saying that it is the thing that has to be used. There are a lot of modifications still have to be done, but some early experience seems to show that this has got some promising benefit. Can be used on some sick patients who are not fit for surgical procedures, but not in all patients. But I think more modifications, I think we'll have better stents. I think we should be doing very well with this. This is how it is done. We have a double balloon that is passed into the proximal jejunum. Both the balloons are inflated, and the segment in between is instilled with blue colored methylene blue solution.
And I've called him. I'll log in before 5 minutes.
Two slides and it's over. Then we put in a stent between the stomach and the jejunum. This is just to show you.
Short total which person from where? Just see.
So you can see this is how it is filled up. And then once you puncture the thing, actually it very effectively creates a gastrojejunostomy between the stomach and the jejunum. You can see this And this is shown to be patent actually, and this gives good palliation for some of these patients. Endovascular interventions are being done, especially large varices like this are being coiled and glued using endoscopic ultrasound, and also some tumor ablations are being done, especially for small NETs or functional tumors. Actually, endoscopic RFA is being practiced, but these are all in experiment.
You will sit here.
I'm sure we'll see more and more of this. To conclude, endoscopic ultrasound is continuously evolving and is becoming a big partner for GI surgery. It is used for diagnostics, especially aiding surgeons, especially if you're planning for neoadjuvant therapy in stomatopancreas. I think we need to require a biopsy. Endoscopic interventions, yes, it's become part and parcel of pseudocyst drainage. Walled-off necrosis, certain cases can be done. Vascular interventions, yes, it's bearing big growth into vascular intervention. Endoscopic gastroenterostomy is a new field. I'm sure in the days to come, we'll see more and more of this. Endoscopic RFA is another area which is emerging. Maybe some of these cases can be dealt very effectively using this endoscopic ultrasound. So endoscopic ultrasound is not a competing specialty, but it's a complementary specialty, especially if you know how to use it, where to use it, and you have a good endocrinologist with you. I'm sure it will make a big benefit for you in GI. Thank you so much once again.
Thank you, Dr. G.V. Rao, sir. It was always a pleasure listening to you, and it's a privilege that you are here today. Raja, sir, you want to? Dr. Raja? Sir, please unmute yourself.
Yes, sir. It was very informative talk, sir, and it was a privilege to listen to you. Thank you very much.
Sopimal, sir, you're there? I think sir is busy with other thing. Sir, thank you, sir.
No, I can't talk. I can't talk.
Okay, sir. Thank you, sir. We'll move on to the next. Thank you so much for coming, sir. We'll move on to the next topic, that is targeted therapy in cancer. Aparna, you're there?
Yes, ma'am.
Yeah, you're ready?
Yes, ma'am.
1 minute.
Ma'am, I would like to share my screen.
Yeah, we are yes, in that process. Yeah, this is Dr. Aparna to you. She's a medical oncologist from Shimoga. Aparna, can you see the screen now?
Yes, ma'am. Yes, ma'am.
Yeah, you can start.
Ma'am, may I share it from my screen so that it will be easy?
I can do it. I can do it, no problem.
Okay, ma'am. But if you make me the co-host, it will be easier, ma'am. Otherwise,
we already started the screen sharing, so I thought 1 minute. 1 minute. Srivatsa. She's the one. Dr. Srivatsa. Yeah, yeah, you're the co-host. You're the co-host.
No, ma'am.
No?
No, ma'am. I've logged in as Dr. Aparna Shivatsa, ma'am.
Oh, okay. Wait, just a minute. Yeah. No. Yeah, there's one more Srivatsa there.
Yes, ma'am. Yes, ma'am.
Okay. Now?
Post disabled.
Stop sharing. Yeah, you're the co-host now. You can start sharing.
Yes, ma'am. Yes, ma'am. I'm starting. Yes, very good evening to everyone. And first of all, I would like to thank the organizing committee for giving this opportunity. So we have listened to many lectures regarding surgeries from morning till now. So this is a different perspective. It is targeted therapy in cancer. So whenever surgery is not possible or you need an adjunct to surgery like a neoadjuvant aspect, then comes the role of targeted therapy in cancer. So I have nothing to disclose. The agenda is, let's see the pathology and molecular biology of cancer to understand the origin of targeted therapy. And just with a few case presentations, I would like to highlight the use of targeted therapy in lung and breast cancer. So when we consider the pathogenesis of cancer, cancer is a genetic disease. So there are two types of genes, the oncogenes, which promote cancers, and the tumor suppressor genes, which inhibit the formation of cancer. So whenever there is an imbalance between oncogenes and tumor suppressor genes, that is when the cancer originates. And we know that it's a multi-step carcinogenesis. It takes multiple years and even decades for formation of cancer. So when we consider the molecular biology of cancer, on an average, any cancer has anywhere between 50 to 150 mutations in any cancer specimen. So we divide these mutations into two types. They can be either driver mutations, which drive the formation of cancer, or they can be passenger mutations, which are like telltale signs of an insult. Like in smokers, we see multiple mutations, we see up to 200 mutations, but not all the mutations drive the cancer formation. So the targeted therapy works by inhibiting the driver mutations, so that the growth of cancer is slowed down. So we have this age-old chemotherapy with us. We have been using it for last 75 years, but chemotherapy has its own demerits. So it acts only on the dividing cells, and it cannot differentiate between the normal cells and cancer cells. So thereby it causes multiple side effects to our hair follicles, causing hair loss, nausea, vomiting, and multitude of effects like mucositis. So this concept of targeted therapy was conceived by the German physician Paul Ehrlich, who is also considered the father of chemotherapy. So he came up with this idea that instead of giving a non-specific agent like chemotherapy, why not come up with agents which act only on the tumor cells like magic bullets. They should hit only the target and shouldn't have side effects. So that is the concept of targeted therapy, where we just we detect the targets and we give agents which affect only the target tumor cells. So we consider the difference between chemotherapy and targeted therapy. Chemotherapy is very non-specific. Usually it's given as intravenous and it is cytotoxic, whereas targeted therapy is very specific to the tumor targets, and most of them are oral agents, and they can be cytostatic or cytotoxic. So in chemotherapeutic agents, we have multiple chemo agents which affect the dividing cells, whereas we have multiple targeted therapy which affects, when we consider hematological malignancy, we have for CD20, we have rituximab. And when we come to solid tumors, we have many agents which are affecting the epithelial growth factors like EGFR, HER2, VEGF, and they have come up in a very big way in treatment of patients with cancer. So till now, we were banking on histopathology and the histopathological variants of cancer to treat cancers. But now we have moved beyond histopathology and we are looking into the genetic modifications, and we are searching for targets in cancers. And that is how we have come up with this tailor-made customized molecules, the targeted therapy. So first, let's see lung cancer. Earlier, we were differentiating lung cancers as small cell and non-small cell. In non-small cell, we had adeno and squamous. But now we have moved beyond the histopathology, and in adenocarcinomas, we are looking for EGFR, ALK, and other various mutations, and we have the many drugs which are very specific for these targets. So today the treatment decisions are based on the genetic mutation, the driver mutations which are driving the cancers. So here is my patient who was a 78-year-old male. He came with cough and breathlessness of 15 days duration. He was a hypertensive non-smoker, a retired teacher. He came with a right lower lobe pneumonia with pneumonic effusion. While he was getting ventilated for pneumonia, he developed seizures. So we evaluated him, and we found out there was a mass in there was a suprahilar mass with effusion, and he also had multiple mediastinal lymph nodes, bilateral lung nodules, multiple liver lesions, multiple lytic lesions in the skeleton, and MRI also showed a solitary brain metastasis in the frontal lobe. So we went ahead and did a biopsy, and we came to know that it was an adenocarcinoma, and there was EGFR mutation which was positive. So the patient was started on erlotinib, which is an EGFR tyrosine kinase inhibitor, and it's an oral drug, and it had mild toxicity like rash and dry skin, and he is in our follow-up for last 15 months. He's seizure-free, he's ambulatory. So we are talking about a 78-year-old man who was very sick, who was ventilated. He has brain mets, and he's surviving for more than 15 months with a very good quality of life. So they are indeed magic bullets, and he didn't have any admissions for chemotherapy, no IV lines, and just a tablet every day, and he's doing wonderfully. So that's how the target, not only erlotinib also crosses the blood-brain barrier, and it is controlling his brain metastasis also. Otherwise, when there is brain metastasis, we usually conventionally we say that with treatment 6 months and without treatment 3 months. But we have moved beyond 15 months, and in a very elderly gentleman, we have given very good results. So we have multiple targeted therapies which they are giving wonderful results. So coming to breast cancer, which is the most common cancer in women in India. So in breast cancer, from beyond ductal carcinoma and lobular carcinoma, we have moved on to doing hormone receptors and HER2 receptor. So when HER2 and hormone receptors both are negative, we call them triple negative. So let us see how in breast cancer targeted therapy has changed the landscape. So for this HER2, let's just concentrate on HER2 positive breast cancer. We have trastuzumab and pertuzumab, which inhibit the HER2 receptors, and they have given wonderful results even in stage 4 breast cancer. So here is a 43-year-old lady who presented with breast lump of 3 months duration. Right axillary lymph nodes were positive. We did a PET CT, which showed a right breast primary as well as a solitary liver metastasis, solitary bone metastasis. Histopathology was invasive ductal carcinoma. She was a hormone receptor negative and HER2 positive. So we started her on docetaxel, cyclophosphamide with targeted therapy trastuzumab for 6 cycles. And at diagnosis, so she had this breast primary, which resolved after trastuzumab and chemotherapy, and the liver metastasis regressed after treatment. So we are talking about a stage 4 breast cancer. We are giving very good responses with targeted therapy as well as chemotherapy. So not only trastuzumab, we have pertuzumab, we have TDM1, and there we are giving survival rates up to 5 to 6 years in patients with metastatic breast disease. So the take-home message is cancer is a genetic disease with targetable driver mutations, and targeted therapy marks the era of customized, personalized medicine. And with the advent of targeted therapy, the cure rates, the response rates are steadily increasing in many cancers. Thank you for this wonderful opportunity.
you, ma'am. Thank you for the session. It was a very informative talk. And I would thank Dr. Raja for sharing the session. We are moving on to free papers, which will be chaired by Dr. Anil Kumar, who is a head of Baptist Hospital, and Dr. Prashant S. Murthy, and who is a consultant surgeon in Chikballapura. The first paper will be presented by Dr. Nagashri. Dr. Nagashri, are you online?
Yes, sir. Yes, I am online.
Okay. Thank you.
Yeah. Yeah, please go ahead.
Thank you, sir. Thank you so much.
Okay, this session is for 10 minutes, 8 minutes for presentation and 2 minutes for discussion. Your time starts now. You can start presenting.
Yes, sir. Good evening. This is Dr. Nagashri. I'm a general surgery postgraduate posted in the Department of Pediatric Surgery from BMCRI. Today I'll be presenting a paper titled Meconium Mocktail, the Ingredients in the Newborn. The meconium is a sterile mixture of epithelial cells, mucin, and bile. Meconium ileus is the cause of intestinal obstruction from inspissated meconium in terminal ileum in neonates, usually occurring at the ileocecal valve. In some cases, it is accompanied by meconium pseudocyst and rarely meconium peritonitis. And rarely atresia can also present in meconium peritonitis. Next slide, please. It can either be simple or complicated. Meconium ileus is commonly associated with cystic fibrosis. It occurs in approximately 16% of patients with cystic fibrosis. The incidence of meconium peritonitis is 1 in 35,000 live births. Due to abnormalities of the exocrine mucus secretion and pancreatic enzyme deficiency, the meconium differs from normal meconium. That is, it has lesser water content, that is 65%, as compared to 75% in normal meconium. And also, in the absence of normal degrading enzymes, intestinal mucus is more viscous, resulting in thick dehydrated meconium that obstructs the intestine. Coming to the aims and objectives, my study aims at studying the clinical presentation and findings in cases of meconium ileus presenting in our hospital, and to study the outcomes and survival rates of complicated and uncomplicated meconium ileus, and to study the demographics of meconium ileus cases. This is a retrospective study on 17 patients with meconium ileus presenting in the Department of Pediatric Surgery, BMCRI. I have collected the data from January to February 2021 from electronic database, discharge summaries, OT, and death registers. Next slide. Next slide, please. My observations were 71% of the total cases were term babies and 29% were pre. Next slide. 82% were male babies and 18% were female babies, and 47% had low birth weight and 53% weighed normal at birth. These babies had presented to us with the symptoms of not passing meconium, vomiting, and abdominal distension. Therefore, they were evaluated to rule out other causes of intestinal obstruction like Hirschsprung's disease, intestinal atresia, midgut volvulus, and anorectal malformation. X-rays were done, and X-rays showed dilated bowel loops, ground glass abdomen with variable presence of air fluid levels. The air fluid level is variable because of the viscosity of the meconium, and even in complicated cases showed calcifications. Lower GI contrast X-ray was done, which is both diagnostic and therapeutic. It showed colon of small caliber, that is, which is called microcolon of disuse, mostly containing inspissated rabbit pellets of meconium. Next slide, please. These cases, out of these 17 cases, 6 were uncomplicated, and they were managed conservatively using contrast urographin enema and rectal washes, and they responded well. The remaining were operated. Of the six uncomplicated cases were managed conservatively, whereas one complicated case died before OT, and the remaining remaining patients laparotomy was done, of which 7 patients underwent ileostomy, One patient underwent resection anastomosis, and 2 cases they were non-salvageable cases in which due to multiple perforations and non-viable bowel, the abdomen was closed back. Next slide, please. Of the complicated cases, 1 case had ileal atresia and 5 had associated pseudocyst. Next slide. This is a case of meconium ileus with pseudocyst. This was a 4-day-old baby which presented to us with symptoms of abdominal distension and not passing meconium since birth. We evaluated the baby. The plain X-ray showed dilated bowel loops and a pseudocyst. The patient was taken up for OT, and intraoperatively meconium pseudocyst and jejunal atresia were noted. The proximal 5 centimeters of the jejunum, of the atretic jejunum, was resected and end-to side anastomosis was done. Next slide, please. There were 4 deaths, all of which were complicated cases with features of peritonitis. The cause of death in all of these cases was sepsis. All of them were term babies with normal birth weight. 3 of them were post-op death. 2 patients underwent ileostomy and 1 had undergone resection anastomosis. Coming to the discussion, meconium ileus is one of the causes for intestinal obstruction in a neonate. The presentation can be either simple or complicated. Complicated meconium ileus being associated with volvulus, gangrene, atresia, or perforation, resulting in meconium peritonitis or meconium pseudocyst. Initially, meconium peritonitis is a sterile chemical peritonitis occurring during gestation. After delivery, bacterial superinfection may occur with colonization of the GI tract. The conclusion of my study is 35% of the patients presented with simple meconium ileus, whereas the remaining had complicated meconium ileus. Some cases were operatively managed, which were usually complicated cases. Mortality was 23% seen major cases. Next slide, please. So I conclude by telling that meconium ileus is one of the causes for intestinal obstruction in newborns. Simple cases can be managed conservatively. If not associated with cystic fibrosis, the prognosis is generally good. Higher mortality is seen in complicated cases due to bowel pathologies. Next slide. These are my references. Thank you.
Yeah, it's a good presentation.
Thank you, sir.
Yeah, it's a good presentation. Now, why is your the title of presentation as meconium mocktail? Why did you think of meconium mocktail as your title?
Because, sir, it has varied presentations. Like meconium, it can be associated with meconium pseudocyst, atresia, peritonitis, and even simple meconium ileus. So I just clubbed together and I made it as a meconium mocktail.
Okay. Okay. Nice presentation. Good.
Thank you, sir.
What was the percentage of male and female babies?
Male babies were higher, so it was almost 80%. Remaining were females.
What might be the reason for that? Do you think there is a particular reason, or
I don't think
it was just an incidental finding?
It's an incidental finding, sir, because my case, my number of subjects are also less, so it's only 17. So it can be an incidental finding only.
Okay.
Thank you, Dr. Nagesh.
Thank
So
you.
any questions, sir?
Yeah. Yeah. Thank you.
Next speaker.
Okay, thank you, Dr. Nagashri.
Thank
We'll
you.
be moving on to next speaker, Dr. Anchita.
Hello, sir. Good evening, sir.
Yeah, good evening. Yeah, start your presentation.
Yeah, you're screen sharing it.
Good evening, everybody. I, Dr. Anchita from the Department of General Surgery, Saptagiri Institute of Medical Sciences, will be presenting my paper on the current trends in the management of lower limb amputations done under the guidance of Dr. Sushant. Lower limb amputation is one of the major, can I have the previous slide, please? Previous slide. Lower limb amputation is one of the most ancient procedures with a history dating back to 2,500 years to the time of Hippocrates. It has been estimated that a roughly of 0.62 amputees in India are present per 1,000 population. I'm sorry, can the previous slide be played? The first slide. Thank you. According to a census of India of 2011, amongst the total number of disability patients, 20.3% have disability in movement. Amongst that, trauma, complication of diabetes mellitus, and peripheral vascular disease are some of the common indications. Lower limb amputation is considered the last resort when limb salvage has failed or when the limb is non-functional or endangering the life of the patient, as in the case of sepsis. The loss of a limb by any individual has profound economic, social, and psychological effects on the patient as well as their families. The aim of this study was to study the various indications, demographics, and complications of limb amputation at a tertiary care hospital in South India. Next slide. This was a prospective study which was carried out from December 2019 to December 2020 at the Subsidiary Institute of Medical Sciences and Research Center in Bangalore. All consecutive cases of lower limb amputation done in the Department of General Surgery during this time period were included in the study, along with taking the patient's informed consent. The decision to amputate the limb, the indication for the amputation, and the level of amputation were decided by the attending surgeon based on clinical evaluation and radiological investigations like X-ray, CT angiogram, and Doppler studies. Above knee amputations were carried out using fish mouth incision, and below knee amputations were carried out using the Burgess technique or the long posterior myocutaneous flap. On post-op day 4, dressings were removed and patients were mobilized. Regular dressings were carried out for the patients in the post-operative period, and in case of development of any post-operative complications, necessary measures were taken. The patients were subjected to regular physiotherapy post-op, and all the patients were followed up till discharge. Coming to the results of the study, a total of 32 patients were enrolled in the study, out of which 87% were male. Most commonly, that is 17 of our patients were in the age group of 40 to 60 years. Next slide. The most common level of amputation was below knee amputation that was done in 12 of our patients. Next slide. The most common indication for the amputation was peripheral vascular disease, as seen in 14 of our patients, and complications of diabetic foot, as seen in 13 of our patients. We also carried a survey as to how many of our patients were tobacco consumers, and a total of 20 patients were tobacco consumers, out of which 14 were tobacco smokers. Next. Post-operatively, only 9 of our patients developed post-operative complications, out of which surgical site infection was the most common complication seen in 4 of our patients. And when swabs were sent for the culture, Staphylococcus aureus was the most common organism isolated. Next. Additional procedures like wound debridement were done in 7 of our patients, and stump revision was done for 4 of our patients. Next. Coming to the discussion, according to METS, the global prevalence of disability is 4% in developing countries and 7% in industrialized countries. The male preponderance amongst the amputees in our country, in our study, that is 87%, was in agreement with the findings made by the other authors. Majority of our patients were in the age group of 40 to 60 years, that is 53.13%, which was also comparable with other studies. Some studies reported a lower peak age, that is less than 45 years, which may be due to the variation in the cause, as well as patterns of amputation, which tend to vary in between countries, as well as between hospitals in the countries. Next. In our study, peripheral vascular disease that progressed to gangrene was the most common indication for major limb amputation, as seen in 43.75% of our patients, followed by complications of diabetic foot ulcer in 41% of the patients. This was uncommon than the trend, which states that complications of diabetic foot ulcer is the most common cause, as per studies done by Masood et al., Nether et al., and Avorikio et al. This may be because of the higher tobacco consumption rates in India. According to the Global Adult Tobacco Survey carried out in India by the Ministry of Health and Family Welfare for 2019 and 20, 34.6% of the adults were tobacco consumers, out of which 47.9% were males and 20.3% are females. Next. Below knee amputation was the most common procedure performed in our study that was seen in 37.5% of our patients. Some studies done by Unikrishnan et al. And Kidmas et al. Reported to have above knee amputation as the most common procedure performed, as seen in 53% and 48.9% of their patients, respectively. Late presentation with spreading gangrene or advanced diabetic gangrene may be the cause in such cases. The complication rate, which was 28.13% in our study, was lower in comparison to another study done by SO et al., which showed a complication rate of 32%. Surgical site infection was the most common complication, and Staphylococcus aureus was the most common organism cultured, which was similar to the microbiological trend that was reported by other authors. The rate of reamputation in our study was 12.5%, which was lower than the rates of reamputation noted in other studies by SO et al., which showed a reamputation rate of 28%. These differences were maybe because of a late presentation of the patient to the healthcare center. In conclusion, peripheral arterial occlusive disease progressing to gangrene and diabetic foot are the most common indications for lower limb amputations. And majority of these lower limb amputations can be prevented by A, health education, that is by enlightening them about glycemic control, by diabetic diet, as well as timely medications, a foot care in diabetic patients, the cessation of tobacco use, and regular health checkups. Early presentation to the healthcare center for early interventions can also help prevent the lower limb amputations. These include intravascular thrombectomy or bypass grafting for intravascular occlusive disease, or control of blood sugar levels by use of hypoglycemics, and proper management of the diabetic foot ulcers. These are my references. Thank you.
Okay.
Paper is open for discussion. Dr. Anil sir and Prashant sir.
Yeah. See, it's a nice presentation. One thing is, how many guillotine amputations did you do, and how many did you close the flaps?
Sir, guillotine amputations, we did a total of 3 patients, sir.
And was there in any case of peripheral vascular disease, did you attempt any revascularization procedures?
Yes, sir, we did. Yes, sir, we did actually. One patient was done in our institution itself. The patient had undergone a femorofemoral crossover bypass grafting, and after 1 month, the disease did not settle, and it demarcated itself when patient presented to us with the gangrene of the left lower limb, sir. So we carried out above knee amputation for the patient. The other patient, he had gotten an femoral thrombectomy done from another institution and had then presented to us after 6 months. That patient also underwent below knee amputation, sir.
See, all these are all old. This one. What is the most recent advance? What is the recent trend in what you have presented? What is the recent trend?
With the upcoming trends in the interventional radiology, sir. So through the interventional,
isn't it?
Yes, sir. Interventional radiology, we can go for percutaneous angioplasty, sir, which is upcoming for such things, or thrombolysis can be carried out.
No, was it done in your study? Any one of the studies?
No, sir, not yet.
No. Okay. Okay, then. Thank you.
Thank you, sir.
Sir Prashant, sir, you can take.
Yes, sir, that's it. Thank you.
Thank you, sir.
Thank you, Dr. Anchita. Next person, Dr. Arvind. Are you in? Dr. Arvind, please unmute yourself.
Yes, sir. I'm ready, sir.
Okay, you can start your presentation. 8 minutes.
Yes, sir. Thank you, sir. The validation of repasses scoring system for diagnosis of acute appendicitis under the guidance of Dr. Ishwar R. Hosmani, Professor in Department of Surgery. Next slide, please. Come to the introduction part. A careful assessment of the abdomen and clinical correlation is one of the most important diagnostic methods and is the cornerstone of management of many conditions of abdominal pain. Acute appendicitis is one of the most common causes of acute abdomen in practice of general surgery. Over the years, different forms of investigations, including laboratory and radiological, have been analyzed in depth with the help of trials. They were performed in the hope of discovering the most sensitive test for acute appendicitis. However, despite significant advancements, In the field of medicine, numerous clinicians and authors have consistently opined that appendicitis is a condition where diagnosis relies primarily on clinical features. Next slide. Next slide, please. Appendicitis, which if caught early and properly treated, may be the most uneventful surgery, although the other end of the spectrum is also true that appendicitis, when missed, can turn into a disease with high morbidity and mortality. As a result, having understood the significance of early and proper diagnosis and having understood that clinical assessment is a safe and most reliable diagnostic tool for appendicitis, a variety of clinical scoring systems have been developed over the years. Started as a single score system has evolved over the years, with people continuously modifying current scoring system on the basis of local demographics or adding more variables. This brought with it the next challenge, the finding of a single best scoring system or a scoring system with maximum sensitivity and diagnostic accuracy. As a result, several experiments have been performed in randomized controlled trials comparing various scoring systems in different parts of the world. Next slide, please. To date, Alvarado and modified Alvarado scoring system have become the most widely used scoring method in the world. As a result, they have almost been considered as undocumented gold standard scoring system by clinicians worldwide, so much so that any new scoring system that has been developed is usually first compared to this. Ripasa score, which is a Raja Istri Pengiran Anak Salahe appendicitis score, is a fairly new score system developed in 2008, where a study was conducted in Ripas Hospital to find a more favorable scoring system than Alvarado and modified Alvarado, as these have found to be have low sensitivity and specificity in the Middle East and Asian populations. In this study, Ripasa and MAS are compared among the local population in the Indian subcontinent to find out which scoring system is appropriate and applicable. Coming to the aims and objectives, this is to validate Ripasa scoring system and to compare Ripasa versus modified Alvarado scoring system. Next slide, please. Inclusion criteria being all patients presenting with right iliac fossa pain were included, and the exclusion being the patients with non-iliac fossa pain and admitted under other specialties. Next slide, please. Coming to the methods of collection, study conducted at Karnataka Institute of Medical Science, Hubli, for a period of 1.5 years from November 18 to May 20. 180 patients were who presented to the surgical OPD and emergency department with RIF pain were included in the study. Relevant history, examination, laboratory findings were done, and a mass and Ripasa scoring was applied, and all the after final scoring, patients were characterized into 4 groups. 4 groups being the definite, high probability, low probability, and unlikely, wherein Ripasa score with more than 12 score is included in definite, and 7.5 to 12 is included in high probability, 5 to 7 in low probability, and unlikely in less than 5 scores. And mass being more than 8. So previous slide, please. Yes, mass being definitely in more than 8 score, and 7 to 8 score in high probability, and 5 to 6 as low probability, and less than 5 in unlikely. Next slide, please. After this, the management of the patient was carrying about according to the Ripasa scoring system. Patient who fell under high probability and were taken for surgery after confirmation. Patients who fell under low probability were subject to the further instant for diagnosis. Patients who fell under U category were worked up for the other causes of pain abdomen other than appendicitis by means of imaging and other appropriate laboratory studies. Conservatively managed patients were discharged and followed up in the OPD, while the patients who were operated were upon directly. Diagnoses were confirmed by intraoperative findings and HP report. The diagnosis confirmation got either by CT scan or intraoperative findings or post-operative HP. Analysis was done comparing both Ripasa and MAS. Coming to the results, most of the patients belong to the age group of 15 to 35 age group. Next slide. The gender prevalence, male being 110 and female being 70 among the 180 group. So the Ripasa scoring when applied, 8 patients showed definite appendicitis and taken up for surgery, and the high probability group of 43 were conferred with USG and taken up for surgery, and low probability group of 62 patients, and with 67 patients being unlikely. Next slide. This is a mass scoring system. 18 patients with definitive and high probability 17, and low probability with 40, and unlikely 105 patients were there. Among all these, 110 patients were found to be acute appendicitis. Here, 110 patients were after diagnosis using ultrasound. 110 patients were found to be acute appendicitis. 3 were appendicular abscess, and 3 were ileocecal TB, and the cystitis being 8, and PID 15. And ovarian cyst or torsion being 5, and 36 with right ventricle calculus. Total it was 180. And treatment modalities were open appendectomy upon emergency basis was done for 93 patients, and conservative management for 16 patients and 1 patient with laparoscopy. Total 110 patients were there. So comparison with the Repasa scoring, 46 patients were came under high probability and definited, and 58 under low probability, 58 were appendicitis and 4 were not appendicitis, and there was 0 with appendicitis when the patient when the Repasa score showed unlikely. From the mass, appendicitis was seen in 30 patients with high probability and 39 patients with low probability, and 35 patients with unlikely, and 70 patients with were not appendicitis under the mass category. So comparison between the Repasa and mass scoring system, where sensitivity of Repasa was found to be superior over the mass in all these values. So 47% versus 28, and 97 versus 93, and positive predictive value 96 versus 85, and negative predictive value 57 versus 48, and the diagnostic accuracy being 68 versus 56. So this is a graph showing comparing Repasa and mass scoring system with patient diagnosed with appendicitis. Here 90% of Repasa scoring fell under high probability and definitely category, and with Repasa 93% fell under the low probability, and 97 being in mass with low probability, and 0% fell under unlikely in Repasa, and 33% of appendicitis fell under the unlikely. So discussion from the time the concept of clinical coding system has been introduced, multiple studies have been studied, done in research of more sensitive and specific and diagnostically accurate clinical score. So it's since Alvarado was the most well known, its modification mass has been equally in common use. As this point of more popular and commonly used system, we plan to compare neuroscoring systems with PASA in terms of sensitivity, specificity, and diagnostic accuracy. Next slide. In the present study conducted 180 patients were included, and Repasa and mass were compared, and the final diagnosis were analyzed using CT, ultrasound, intraoperative findings, and postoperative HP reports. It was found that I already discussed all these things. Next slide, please. Even though mass is a routinely used scoring system for the diagnosis of acute appendicitis worldwide, it has found to be lacking in sensitivity and specificity. Analyzing both Repasa and mass, it was found that Repasa and mass were easy to perform, as they mainly relied upon clinical symptoms and signs along with basic laboratory investigations, and did not go to elaborate investigations. As Repasa had more number of parameters, subjectively it felt like summarize the patient clinical condition better. Next. Conclusion, the present study concludes that in the diagnosis of acute appendicitis, Repasa score is more specific than mass, and also has a higher predictive value on the diagnostic accuracy. It gives a clear categorization on management of RF pain suggested in most of the cases. Repasa also reduces the number of missed appendicitis cases. Hence, Repasa is clinical and statistically better scoring system for diagnosis of acute appendicitis as compared to mass. Thank you.
Okay, so it's a nice presentation. Now, yeah, how many children were there in your study?
So around 20 were the children, sir, coming under.
In those 21 children, what was which one was more significant, Repasa or Alvarado?
Repasa, sir. When Alvarado says it is definitive high probability, then it is definitive appendicitis, sir.
Okay. Fine. Okay, thank you.
Yes,
the final diagnosis of appendicitis was made on histopathology, is it?
Sir, final diagnosis, when operated, it is done under HPA, sir.
Okay. How did you categorize the patient into Alvarado and Repasa? On what basis?
We have applied the scoring system to all the 180 patients using the Repasa and modified
Alvarado.
Sir. Okay. But management was carried after Repasa scoring, sir, based upon the Repasa scoring, sir.
Fine, thank you.
Yes, sir. Thank you, sir.
Thank you, Dr. Arvinda. The next paper is from Dr. Muni Kumar. Are you ready?
Yes, sir. I am ready, sir.
You can start your presentation.
Okay, sir. Thank you, sir. Good evening, respected professors. I am Dr. Muni Kumar Amuru from Chitnod Hospital, second year postgraduate. I am going to present a free paper on delta neutrophil index as an early predictor of a complicated appendicitis. My guide is Professor Dr. Loknathan, sir, Chitnod Hospital, General Surgeon. Introduction. The acute appendicitis is one of the most common causes of acute abdominal pain. The usual signs and symptoms are often atypical and vary greatly from every patient. The accurate diagnosis of acute appendicitis is based on careful history, clinical examination, laboratory and imaging findings. The increased time period between the symptom of onset and the surgical treatment is risk factor of ruptured appendix. Next slide, please, sir. There are several blood tests are used to aid diagnosis of acute appendicitis. Approximately 80% of the patients are known to have leukocytosis in acute appendicitis, but elevated white blood cell count has a low predictive value because WBC is also elevated in up to 70% of the patients with other causes of right lower abdominal pain. So there is elevated C-reactive protein levels are common in acute appendicitis, but studies disagree on its sensitivity and specificity. A more recently suggested laboratory evaluation is the determination of neutrophil to lymphocyte ratio and platelet to lymphocyte ratio, but their sensitivity and specificity is also not more sensitive and specific than that of compared to that for total counts and C-reactive protein. Next slide, please, sir. So coming to the delta neutrophil index, normally the immature granulocytes are an indicator of increased myeloid cell production and are known to increase in infectious and inflammatory conditions. The delta neutrophil index is an acute phase reactant that elevates rapidly in response to inflammation within 2 to 3 hours after the inflammation response has started. The delta neutrophil index measures the fraction of immature granulocytes in the circulation. Delta neutrophil index indicates some increase in myeloid cell production during inflammation. Next slide, sir. Okay. The value of delta neutrophil index is very useful in planning the management of acute appendicitis. The delta neutrophil index is calculated by neutrophil percentage plus eosinophil percentage minus polymorphonuclear neutrophil percentage. By this formula, we'll get if the DNA value is more than 0.2, it indicates more accurate diagnosis of acute uncomplicated appendicitis. If the DNA value is more than 0.6, it indicates a more accurate diagnosis of acute complicated appendix like rupture or perforation or gangrene. Next slide, please, sir. Justification of the study. This study is undertaken to compare the preoperative delta neutrophil index with the intraoperative and histopathological report. It is a cost-effective study, can be done along with the routine investigations. It's a not time-consuming study. It's useful in early diagnosis and it's a prompt intervention. Next slide, sir. The aim of the study is to evaluate the usefulness of delta neutrophil index independently as an early predictor of acute uncomplicated appendicitis and acute complicated appendicitis. The objectives of the study were to show DNA is an early predictor of complications during appendicectomy and to demonstrate DNA is better biomarker for a planning surgical approach in case of appendicitis. Materials and methods of the study. The study design was a prospective study. The study area was Chettinad Hospital Research Institute. The study population was 5 kilometers from our college. Type of the study is prospective study. The study patients diagnosed with acute appendicitis clinically were selected. All routine investigations along with the DNA were done. If the DNA is more than 0.6, which is sensitive for complicated appendicitis, is noted. If DNA is more than 0.2, which is comparable to acute uncomplicated appendicitis, is noted. Patients were followed during intraoperative and postoperative periods, and the HPA reports were checked out. Both the results were compared to see which is the best predictor for acute appendicitis and acute complicated appendicitis. The inclusion criteria of the study were patients who were diagnosed of having acute appendicitis and age between 18 to 60 years. The exclusion criteria of the study was pregnancy, immunological deficiency in status, or hematological disorders, and a history of GI and hepatobiliary malignancies. The results of the study. Among the 20 cases that underwent the study, 5 cases came to be as a complicated appendicitis, and 14 cases came to be as uncomplicated appendicitis, and 1 came to be as a normal appendix. These are the results comparing the DNA value with total counts, intraoperative and HPE findings. Next slide, sir. The conclusion of the study. According to the results obtained, a DNA of more than 0.2 seems to be a reliable parameter to obtain a more accurate diagnosis of acute appendicitis, and a delta neutrophil index of more than 0.6 may help differentiate between the complicated and uncomplicated appendicitis. The ability of a delta neutrophil index to predict the presence of an acute appendicitis or a complicated appendicitis is only fair. And if a delta neutrophil is less than 0.2, it does not exclude appendicitis, and nor does if it's less than 0.3, it does not exclude a complicated appendicitis. However, if the patient is clinically suspected for acute appendicitis, and a DNA is more than 0.2, prompt confirmatory studies as CT should be considered early in the course of diagnostic process. These are my references, sir. Thank you, sir.
Yeah, it's a good presentation. One thing was, why is that population of within 5 kilometers only included in the study?
So normally, these people come to hospitals normally when compared.
No, anybody else outside 5 kilometers you won't include?
No, not like that.
And now, how come you got only 20 cases to study? Your
Sir,
case number is very, very less, no?
Sir, we applied for IHC approval, sir, for SPM department. They told 20 to 25 is fine.
So was it a pilot study or a complete study? This one, was it a pilot study?
Sir, no, sir, it's not a pilot study, sir. Previous studies were there, sir, based on this.
Yeah, no, in your hospital, was it a pilot study?
In my hospital, this is a pilot study, sir, first study, sir.
Yeah, that's right. Okay, and how did you get this DNA index? Who gave you the DNA index? The lab or you calculated?
So DNA index, my chief told me to do it, sir.
No. What I'm telling is, in a patient.
Lab pathologist, sir.
Okay.
Give me the.
What was the cost?
Sir.
Cost for the DNA.
Not only cost is a normal. It's free of cost, sir. Only the CBC is free of cost.
Fine.
That's
Fine. Okay.
Sir, any questions? Okay, we will be going ahead with the next presentation. Dr. Sharan Basappa, are you there? Sharan Basappa, K. Okay, Dr. Prashant Sai. Dr. Prashant Sai, please unmute yourself.
Yes, sir.
Okay, we'll start with your presentation.
Yes, sir.
Just a second.
Yes.
Your presentation.
Can I start?
Yes.
Yeah, please go on.
Good evening to everyone. COVID-19 is considered as the greatest difficulty faced by the humankind since the Second World War in 1939. My topic for today is to see the effect of this last year's pandemic on surgical residents. Next slide, please. Next slide. Surgery is considered as a complex profession that demands. First slide. Surgery is considered as a complex profession as it places significant demand on an individual. Due to its heavy workload, often surgeons face a difficulty in balancing between their professional and private life. Back, first slide, please. The duty of a surgeon is not only to perform surgeries, but are also responsible for the patient care before, during, and after the surgery. It is estimated that around 300 million surgeries takes place every year. Next slide, please. In India, the surgical demand is about 3,646 surgeries per 1 lakh Indian population per year, out of which most of them are performed by general surgeons. This surgical demand was significantly changed when WHO has declared COVID-19 as a pandemic on 11th March 2020. India noted its first case on 27th January 2020. Next slide. In view of increasing cases of COVID, Government of India has announced nationwide lockdown started from 24th and extended till May 3rd. Among all this chaos, surgical trainees have been uniquely impacted by these changes, as all the elective cases has been suspended and patients walking into the clinics has been drastically reduced. Most of the residents have been sent to COVID wards to care for COVID patients or COVID suspected patients. Next slide. With this background, my aim of the study is to assess the effect of this last year's pandemic among surgical residents regarding their clinical schedules, operative volume, and educational curriculum. Next. We included all the surgical residents who are willing to participate in our study and excluded those who are not willing for it. Next. We did a cross-section based survey from September 2022, December 2020. Data is collected via questionnaire, which was circulated through Google Forms. Our questionnaire consists of 22 questions, which includes demography of the residents and the effect of COVID on their clinical or academic curriculum, or effect of COVID on their surgical load, and some of the general issues faced by the residents during COVID period. Next. 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 Coming to the results of our study, out of a total study population of 127, most of them are males and are third-year residents. Next. Next. 91% said that their institute was a COVID center, out of which most of them has worked in COVID wards. 94% said that their curriculum has been affected due to COVID. 46% said that their curriculum has been completely changed to online, whereas only 7% said that there were no classes at all. Next. 64% said that they could not utilize these online classes to the full extent. Next. With common reasons stating that they are not as interesting as offline classes. Next. 63% of the residents felt that 1 to 2 classes per week would be ideal or feasible for them. Next. More than 60% of the residents have missed their duties for more than or equal to 5 days. Next. 74% felt that there were more conferences, symposiums, and online classes compared to previously. Coming to the surgical load has been drastically reduced, which can be correlated as both emergency cases and elective cases has been drastically reduced. Next. Next. Whereas coming to the laparoscopic surgeries, either they are decreased or totally stopped in some institutions. Next. With the decrease in the surgical load, most of the residents felt that the hands-on experience for them is reduced. Next. Only 24% of the institutes has taken measures to compensate the loss of this hands-on experience by giving them more hands-on on this limited patient, and whereas some of them have started simulation or skills lab in their institutes. Next. Most of them has operated on COVID patients, and next. Next. Almost everyone felt that the pre-op workup of a patient is more hectic compared to previously. 30% felt that the extending course would be a good thing for about 3 to 6 months. Next. Next. 35% has been tested positive for COVID, whereas almost everyone whereas most of them are satisfied with the facilities provided by the institute. Vision issues due to fogging of spectacles and difficulty to operate with PPE kits seems to be the most common problems faced by the residents during COVID period. Most common fears among the first of transmitting COVID to family and friends, followed by increased stress about getting themselves sick. Next. 47% of the residents felt that there were more time for self-study, whereas 44% were more stressed about uncertainty of their exams. 44% felt they were discriminated by the non-medical people as they were avoided by their neighbors as well as close relatives. Next. Coming to the discussion of our study, working in COVID wards and the effect of COVID on curriculum has been correlated with other studies. 46% of our study population said that the curriculum has been completely changed to online in our study, which was found to be 81% in other studies. 47% said that the online classes were ineffective, which was comparatively less. Missed days and residents not allowed to opt OTs seems to be same when compared. 47% felt that there was more time for self-study, which was 20% in other studies. Difficulty in operating with PPE seems to be the most common problem faced by the residents during COVID period. Next. 30% of the residents felt that the extending course would be a good thing, which was comparatively 62% with other studies. Transmitting COVID to family and friends and contracting COVID to self seems to be the most common fears among the residents during COVID period. Next. With this, I would like to conclude by saying that COVID-19 has affected the training of surgical residents in clinical aspects and operative volume to a major extent and to a minor extent on their educational curriculum, as it is being maintained via online platform. Even though educational curriculum is being maintained via online platform, most of the residents felt that they could not utilize these online classes to the full extent. With our study, I would like to suggest that there is a necessity of streamlining of webinars, that is, organizing the classes at the timings which are feasible for the residents, and including classes on operative planning and surgical videos, which can compensate the loss of surgical experience. Starting a skills lab or simulation lab would also be helpful in improving their surgical skills. These are my differences. Thank you.
You told that
paper is open for discussion.
The conferences and seminars were more earlier. That has been told by some percentage of the people. The conferences and seminars were more in the pre-COVID time.
No, sir. During COVID period, there were more conferences or online classes when compared to previously, which was said by most of them. Because
more conferences,
of this, I mean, more online classes and more conferences they can attend because of this online platform. They could attend more conferences, sir.
Online.
Yes, sir. Because of online this one, they could attend more classes and more online conferences.
Okay.
Yes.
Yeah. Now, one more thing. Was the PPE which they provided, was it adequate for the surgical residents? Because many times we found the surgical residents not having PPE, complaining and all the thing. Did you find anything about that in the study?
Yes, sir. But during COVID, I mean, but most of the institutes, which most of the residents which we have given this questionnaire, most of them felt that the facilities, I mean, the PPE kits and all, they felt that they felt it was enough for them. I mean, they were satisfied with the quantity, at least they were given to them.
Okay, and it is little surprising that the surgical residents are asking for extension of the course, isn't it?
Yes.
Do you want?
Yes. Yes, sir, definitely.
Okay, that's nice presentation.
Thank you, Dr. Prashant.
Okay, sir.
And Dr. Sharan Basappa, are you there? Dr. Sharan Basappa? Okay, so we can conclude the session. Thank you, Dr. Anil Kumar sir and Dr. Prashant sir. Thank you for taking the session, sir. Thank you so much.
Thank you. Thank you, sir. Sir, when do you want us to give the results, sir? Do you want us to mail the results or what is it?
Sir, please send it to Dr. Gaddi Divakar, sir.
Okay, through the mail, no?
Through the mail or WhatsApp, anything is fine, sir.
Okay.
So we'll go to screen one for AGM.
Yes, sir. Yes,
Thank you. Thank you, sir.
Thank you very much. Thanks.
Thank you.